Welcome to Pisa. Welcome to a city of history and arts, home to the world-renowned Leaning Tower. The Italian Surgical Society, SIC, is proud to present an historical event celebrating the publication of a monographic issue of Updates in Surgery, dedicated to the 20th anniversary of robotic surgery. The monographic issue provides current state-of-the-art of robotic surgery. On July 2nd and 3rd, experts from all over the world will convene in Pisa to present their experience and share their opinions. You cannot miss this historical event. The meeting will be held right at the feet of the Leaning Tower, in a breathtaking scenario. We can accept only 100 participants for the in-person event, but you can still join us at the link shown at the end of this video. You can't miss this historical event. We are waiting for you.
Good morning, dear friends. Welcome to this very interesting meeting, and I'd like to thank my friend Ugo Boggi for this kind invitation. Today, I have the pleasure to share my session with Paolo Del Rio, who is in Naples in this moment, but I think that we are able to connect with him. This session This session starts with a small variation of the program, because before the lecture of Ugo Boggi, we have a special speech by Tim Schilk about the future perspective in the Vinci Robotic Assisted General Surgery. Please.
Buongiorno a tutti. Good morning. Dear President, dear Chairman, thank you very much. It is a great pleasure for me to be here in Pisa. I learned a lot yesterday about what Pisa has done for robotics. And I think it's also a wonderful day to talk about science. And I'm very impressed also by what you have done in collecting evidence for robotic surgery. Today, I have the pleasure to talk a little bit and add to your understanding and maybe share with you some thoughts on where we think as a company the future of surgery will lead us. I think everything we do should and must add value to patients, and how we do this, I'd like to share with you. So first of all, if I think about evidence, and this might not be very scientific, but it shares and demonstrates, interestingly enough, how many people in the world have contributed to the sound foundation of robotic evidence. 24,000 publications and increasing is demonstrating that there must be something and some expectations in the value of technology and how this can help to improve healthcare. If we look back a little bit in the past century, if we think what was the big game changers in the past, it's to do surgery without pain, to do transplantations, but also to reduce the access trauma by minimal invasive approach, which is changing the world of surgery again. And I believe that in the 21st century, digitalization of surgery will change again our world. Let's push the door open. Let's have a look into the OR. What is going on here? In addition to traditional, conventional open and laparoscopy, we believe that a different kind of surgery will be present more and more. It's a new, let's say, approach to an old problem, which is minimal invasive surgery. It adds to be maybe more efficient and maybe less stress to the body, but we will talk about it. From a patient perspective, this is how open surgery looks like and feels like. And it's very evident, not only to patients, but also to us as surgeons, that this is a difference. Let's look into Da Vinci technology and what it does. Maybe we have people in the room who need to understand a little bit better what it does, and I'm allowing you to have a little glimpse behind the scenes. So what you do is a hair-thin needle and a thread, which is a suturing movement that you know from surgery. You see now how those movements in the controller unit are transmitted to the instruments that are very thin and small. So the exact same movements are translated to the skin in this example. I show you also the OR setup. You see in the middle a patient card, and you see a console on the left, and you see a video tower. At the console, you see that these movements were translated into the body of the patient with finally a blue cable. The secret of it is that you have sight also, and not only two-dimensional, but three-dimensional, and the picture is very stable, allowing the surgeon to control the surgery at any time visually. From here, it's like a cockpit. You can direct everything and be in control of it. Another option is that you bring in a second console, two cockpits, two pilots, which allows not only to cooperate with maybe a gynecology surgeon and a urologist, but also for training purposes. I'll come to that point in a second. So both surgeons see the same thing and have control over the instruments at the same time. And maybe one other secret of Da Vinci is that you not only have two, but you have 4 arms. So you see 3 blue instruments and 1 camera controlled by 1 surgeon, 4 arms at a time. I'll show you something else, what a computer can do in the operation room. Left, you have translated an instrument without tremor. And on the right side, you have a conventional laparoscopic instrument. And you see also the degree of miniaturization that is realized here. And if I summarize what today Da Vinci technology does is better vision and precision in surgery. And on the right side, you have that control panel, which is like a cockpit. I'd like to discuss a little bit one more. What does precision surgery mean? And I'm taking you into an operation field, and you don't need to be worried. There's no single drop of blood. I have that video from my friend Amjad Parvez, and you see that, first of all, those movements are ultra precise. There is no tremor, and you can very carefully select which structure you want to cut and dissect. If I now tell you that the space that you see is about 1 centimeter, not more than that. And within this centimeter, you can very precisely move and expose. You see that there's a left hand that allows to expose. And I tell you all in addition that this is deep in the pelvis. So it's a very tight space in the body that is difficult to access. And you see how great the vision is. And you are fully in control. Also, what you need to think, if you see a nerve, then why cut it? The crucial thing is that you need to see enough and good enough to be able to spare nerves and vessels. Okay. Let's have a little perspective on where we think we're going. We think this is good. Yes, we believe that it is really good. Question, is this better? Is this promising even less invasiveness, less access trauma? We believe so. We believe that less access trauma is more valuable. We believe that if you reduce the access trauma and still are able to produce complex surgery with 3 arms and 1 camera coming through 1 access port, allows us to be less invasive. It allows also natural orifice surgery, which is even less traumatic. And this computer or system will be called SP and will be integrated into the already existing product lines. But if you think, it's actually not a robot. It is a computer in the OR. The question then is, what does a computer do in the OR? And what we do here is we just combine other digital information that we have at hand already and combine it with our technology so we can see where you normally cannot see. We combine a CT scan here with a tumor in the kidney, which allows us to more precisely dissect and organize a treatment here. I'm showing you something else. So if you do these movements, the computer is able to track your movements in a 3-dimensional way. You have a left hand and you have a right hand. Okay, video analysis. This is maybe not new, but I'd like to demonstrate to you what we think we can do with it. So from a video, probably we can differentiate between an experienced surgeon and an unexperienced. But Let's see what a computer does. We see specific movement patterns of your left and your right hand. And if we see that over the entire length of a procedure, we can identify specific steps in a procedure. And these steps add up to the entire length of a surgery. And if we compare this to an experience, we can say not only the surgery is much faster, but we can identify what steps need to be different in order to achieve a higher level of experience, a greater efficiency in the procedure. I'll show you how we use this. We believe that, first of all, education doesn't stop. I think as surgeons, we need to continue to learn lifelong, probably. So education does not stop at graduation. And this technology in particular became very valuable in a phase that we all are in, which is challenging enough to all of us, in particular to healthcare. But this is not new. We thought before already that this old concept of see one, do one, teach one is maybe no longer valid. We think that technology and digitalization will change our learning interactions. And the way we organize them will be probably different. And in particular, to create greater scaling and efficiencies is the goal. I'll show you here what I call my personal, let me say, experience on the dual console, which I found super valuable in a teaching situation. That means you have an experienced surgeon and then a learning person on the other side, and you can benefit one-on-one to it. And we have created also new training centers that allow, in particular in a phase of a pandemic, to continue surgical education. But as a first step in our training course, we believe that you need to learn about the technology. You get a passport and you have a series of proctorings followed, and I skip a couple of steps here. But the important thing is that continuum, that continues even if you are very experienced in your career, and also come maybe to a level where you as an experienced surgeon give your knowledge back to younger surgeons. And all of this is in alignment with several surgical societies and academic institutions in the world. Some technology also, again, that dual console concept that allows to fly like in a cockpit. In the middle, you see a remote proctoring and mentoring machine that allows to observe the OR from outside, but also from the inner endoscopic picture is transmitted and allows to help over a distance. And I'll talk about simulation in a minute. Here, I show you how it looks like. So as an operating surgeon, you see your endoscopic picture and you see drawings that your mentor digitally can transmit to you. He can talk to you and can observe what you do and help you from a distance. And I'll also show something how simulation works. So you see, and the keyword is maybe gamification. So you see those very awkward movements in the beginning, okay? And the task is pretty simple, first of all. But you see also that within these 20 seconds, we do these sort of trainings, the movements will become smoother and will become more precise. So for these exercises, not a single patient or our room is required. You can train totally independently whenever you feel it is right time. And the same sort of movements get translated into a clinical situation. And all this is still virtual. I give you here the example of an intracorporeal anastomosis. You can select your instruments You can use a virtual stapler and you can arrange your setting as much precise as you can in order to be very time efficient here. We can say that hundreds, thousands of exercises were done worldwide with over 5,000 surgeons that have done these types of procedures. So we can say this works, this concept to bring virtual reality into surgery, helping to create more efficiency. But not only surgeons need to be trained. We believe our teams in the entire group need also an assistance in building efficiency. You very much rely on your team, so therefore they need to be trained. We have tools and ways to help them and educate them, even in a virtual space, which is again important in particular in those challenging times. Beside the body of evidence I was talking about, and we will come back to this later during the day, there is something else going on. It's an app on your iPhone. The question is, what does that app? So I come back to those 25,000 publications. That's a body of evidence. Fantastic. And it shows that there must be some value. Okay. But moving into an app that allows you to have your own data at your hands, create something which is different. It adds up something that you very much believe in. It's because it is your data. And your data is your truth. And your truth will be able not only to inform you about your practice, but I believe also it will change to transform, or will change your practice over time, because it makes you very efficient. You exactly know where and what you should work on or have a closer look at. And that may also assist you in transforming your surgical practice. And many surgeons did in the world. I'm sharing with you the development in the past 20 years or 10 years. And we see that general surgery became quite the biggest and fastest growing segment compared to others that you well are aware. We believe that these different specialties see value in transforming healthcare. We do see that we have a common goal to improve healthcare, and we also believe that digital is great, but we need more than just digital technology.
2 minutes.
Thank you very much.
Okay, thank you. Thank you so much, Dr. Schick, for this very nice presentation. It's a really introduction to all the day. If you like, if you agree, we come back in the discussion. And I would like to remind we have a very intensive program, so stay in your time. Ugo Boggi is the first speaker before to start with the colorectal surgery session, and is an overview about the robotic surgery in these 20 years. Ugo, thank you again, because today we start to relive with after 1 year and a half of pandemic. Thank you again. Okay. We are connected with Paolo. Paolo, can you hear me?
Hi. Just to say hello, I'm very happy to be here, even if it's on web, and I'm really proud to be part of this fantastic meeting. Thanks to Ugo, and we really hope to hear what is the future after such a bright and wonderful past. Thanks.
We already know, I don't see my slides on the screen. So we already knew that, again, I don't see the slides, but we know that the original idea of a robot was from Leonardo. For now, at least, there are no slides on the screen. Non si vedono le diapositive. And so I keep going on my presentation. These are some kind of blah, blah, blah. I mean, for the moment, the robotic surgery actually is Da Vinci surgery. We don't know exactly about the future, but for the moment, it's clearly Da Vinci surgery. The first human operation was a cholecystectomy. It was done in 1997, and the first system was sold to Europe, in Germany, not in the US. And it was in 1998, and it was in the year 2000 that the device got the FDA clearance. And this is why we are celebrating the 20 years, although 1 year later. And again, I don't see the slides, but it's quite the same. But now we have some graphs, and without the slides would be becoming more difficult. What we already seen from the previous speaker is that there has been a dramatic increase in the number of robotic procedures worldwide. To the best of my knowledge, as of a couple of years ago, you have 1,002,000 robotic operations in 1 year in the world. I don't know whether or not this means that robotics is better than something different, but for sure it means that many people are dedicated to this. And now we see. No, that's so as you can see from this graph, there was a dramatic increase in the number of installed robots worldwide. Most are in the US, but you can also see that there are many robots in Europe. And we also know that in Italy there is a good diffusion of robotics. This is what I was mentioning about the number of robotic procedures worldwide. And this is quite nice. Already the previous speaker has said, we believe, and it's true, that the robot is worldwide for urology, maybe for gynecology. But it's intriguing that starting from the year 2010, it became prevalent the use of robotic assistance in general surgery. Of course, general surgery means many things, not just one specific issue. But it's quite interesting that it's not just for urology and gynecology. And of course, as a new device breakup, there were many first ever robotic procedure reported worldwide. This is a kind of warm up. The darker column means from where most procedures were reported. And of course, the most were reported from the USA, also because there were maybe many robots there. But it's quite interesting that Italy comes second in this particular standing. These are the number of first ever reported robotic procedure. You can see that the device was first introduced in 1998, and then there was a peak 5 years later. That means a very quick uptake. And some of these procedures were really major surgery, not just a cholecystectomy. You see, this is pancreatectomy, pancreatoduodenectomy. And then you can see total gastrectomy, rectal anterior resection, and so, transrectal esophagectomy. So these were very complex procedures reported early on. That means that robotic surgery is, I would say, intuitive to use, although it needs training and so. These are our small contributions to this first ever procedure. We did the first European robotic renal transplant, the first world robotic pancreas transplant, the first world fully robotic right hepatectomy for adult to adult liver transplantation. This was done in Palermo, but we did it. This was done at ISMET, but our team did it. We moved a robot there to do this, and we moved a team there to do that, and it was done nearly 10 years ago. And then we did the first world selected distal spleen renal shunt for severe portal hypertension. This is a strange story in the sense that one day the pathologist came to my office and he said, I have this young lady, She has a hepatic fibrosis. She could, but she has very, very severe portal hypertension. She's bleeding very heavily. She has a renal transplant. If I put the tips in, she will need a liver transplant in 1 year. If you can do a minimal invasive Warren shunt, she can live with this for maybe 20 years. And I said, I never thought about this, but my old reminding from the era of portal hypertension, my first picture that I have from the world of general surgery were Sestaken tubes that were led. So I remember that's what the era of portal hypertension. And I said, if the splenic vein is close enough to the renal vein, and I can get there, I can do. Because I remember that this was a question at that time. How far is the splenic vein from the renal vein? I believe that the newer generation don't have these ideas in their mind because they don't know the surgery for portal hypertension. I had a few videos, but for the sake of time, I will skip on most of these. I will just show you this one because this is the first ever robotic pancreas transplant. It's a kind of #1 coin. You see, this was the cava. This is the right common iliac artery. This is a quite large bulldog clamp. You see a small midline incision. And this was 11 years ago. And you can see actually that you could not do this better open. I do recognize that it's tough to organize because pancreas transplant is always nighttime. Robotic surgery is usually an elective kind of surgery. You don't have a robot for emergency surgery. But at the end, you can do it. One thing that is nice, for example, when I do a pancreas transplant, open, I have to retract my pancreas, and I have to reconstruct in my mind how short I have to make the vessels to avoid a kinking. There you don't need that, because the pancreas is already there. You're not retracting the pancreas. And so it makes easier to have, I would say, an ideal geometry of that of these anastomosis. Now we've done, I would say, many kidneys transplant because we can do it from live donors, so we can do it the daytime, and few pancreas transplant because of the struggles I've told you about using the robot at nighttime. It was successful. It was nice. Pancreas transplant is one of my, I would say, my preferred operations, my historically preferred operations, and this is the bleeding that we had the reperfusion. This was the video about the Warren shunt, but I would spare that for you. So in the sake of time, I will directly go to my conclusion. I would say that currently available Da Vinci systems, in my mind at least, just represent the beginning. They don't tell the entire story. They are just the beginning. It's like, I would say, an old mobile phone that was like a true phone. You know, you had to bring it on a backpack, really. And now we have a small computer in our pocket. I believe that the story could be the same for robots in the operating room. Few other systems are already on the market. Sometimes I ask, how is this system? How is that system? Actually, I don't know. We have to verify. We have to check. But we know that some systems are close to be marketed. And this is nice because it means that the industries put energies, money, intelligence to develop that system. And one day on another one, we will have some major improvement. And competition, I believe, competition will hopefully reduce costs and speed up implementation of new disruptive technology. Reducing costs, we all know that is key. It's key because high costs reduce system accessibility. And this is an issue. Sometimes, for example, for pancreatoduodenectomy, I'm asked, how many of your pancreatoduodenectomy you do robotic? And my reply is, how many as I can. It means that I could do more if I have more robotic space. This is not an issue in open surgery or maybe even not in laparoscopy because I can use on an everyday, it's my choice. But using a robot is not just my choice because there is money behind, I have to share with other disciplines. So having a cheaper system would just be a major advancement. So thank you very much for coming to Pisa. Thank you very much for sharing with us, and thank you for your attention.
Thank you, Ugo. Thank you so much for this very nice presentation. But overall, thank you for all your effort to improve the robotic surgery in Italy and the world. Now we are going to start the first session of this very interesting day concerning colorectal surgery. We are connected with China, UK, and so on. So the first speaker is connected by China. I would like to, if possible, also to connect with him, Dr. Onji Din. Hello?
Hello, thank you. Thanks for the chairman. Thanks for the Professor Boggi. Give me the chance to have the presentation. I'm from China. I'm from the PLA General Hospital. I'm a surgeon, major in the gastric and colon cancer. And I wish the successful conference. Thank you.
Okay, thank you. We recorded this presentation, and we are ready to start, please.
Good morning, everyone. I'm Liu Hongyi from the General Surgical Department of the PLA General Hospital, China. First of all, I want to thank Professor Boggi for giving me the chance to talk about the state of the art of colonic robotic resection. To begin with, I want to talk about the robot. I don't think the surgical instruments deserve the name robot. As we call something robot, we generally mean something with high intelligence and free will movement, do things human cannot do. Apparently, the surgical system has no such function. The only so-called AI function is the hand tremor filter. I don't think it is intended to do so. Maybe it's just because it cannot transfer hand tremor into mechanical arms movements. So the robot's surgical system, unlike a robotic soccer player or chess player, Deep Blue, is just a surgical instrument like electroton. So I think it is just a surgical instrument, while I like the name robot. As a complicated surgical instrument, the robotic system does have some merits. It can break through the limitation of human eyes, the 3D images, the real 3D, not like 3D movements, so exaggerated. When we do operations with it, it feels like we are in patient's abdominal cavity, like Avatar, not only 3D, but the mechanical arms with our will are doing the operation. And it has another merit that breaks through the limitation of human's hands. It can completely imitate the wrist movement of a human, and its range of motion is even larger than that of the human hands, more flexible than humans in narrow space. Next, I want to talk about the robotic assisted colectomy and compare with the laparoscopy-assisted colectomy. The robot assisted colectomy advantages in blood loss, rate of conversion to open surgery, rate of complications such as ileus and anastomotic leakage, shorter time to bone function recovery, and shorter hospital stay. And also has disadvantages in longer operation time, higher costs. Two groups are comparative in overall survival and disease-free survival. This is the operative surgical outcomes of patients in our hospital. and also have longer operation time and higher surgical and total hospital costs in robotic surgery. And the two groups are comparable in blood loss, number of lymph nodes harvest, and post-operative recovery. Two groups are also comparable in 3 years overall survival and 3-year disease-free survival. This left one is the central approach, and this one, the right one, is the cephalic approach. In cephalic approach, we separate the colon from the stomach and the duodenum first, then go back to the center approach. In center approach, we first located the iliocolic artery, lift it up, then penetrate the iliomesentery into toed fissure, then dissect the iliocolic vein and artery, blind it, and cut it off separately. This is true also. Also, there are two other approaches. One is the caudal approach, and one is the lateral approach. As a good surgeon, I think we should master all the approaches and choose a portable according to the different situation. And this is the right colon artery vessels, maybe veins in there, and we like it and cut it off. This is the SMV, and this is the pancreas. And this is the right one. This is the middle colon artery. The right branches, we cut it off. This is the pancreas. The left one is the pancreas. And this is the right colon artery. This is the vein. The right video. This is the right branch of the middle colon artery. Then we saw the small gauze there. We put the first. This is this one. This one is the Harris trunk. Just use a back clip to cut it off. Then the left one, we separate the colon from the stomach and duodenum. We last, we separate the colon from the lateral peritoneum. Then we cut off the tumor and do the ileocolonic anastomosis with auxiliary incision. This is the left hemicolonic colectomy. First, we should locate the left cardiac artery. This patient has only one left coronary artery, and this patient have two. No matter how many, just like it and cut it off. This is the IMV. We can see the IMV here. Do not go deeper. This is one of the artery. This is another artery. Patient had two. And this is the left here is duodenal jejunal fracture, not injured, and we cut off the IMV at the root. This is the proximal end, and we cut the distal end first. This is the pancreas, so do not go beneath the pancreas, maybe will cause collateral injury. Make sure go in front of it. This is another IMV. We cut off at the root of the IMV. Then we separate the colon from the lateral peritoneum. This here. This is the pancreas. Just as I said, go in front of it to make sure. Then we separate the colon from the gastric and the spleen. Just cut off the gastric. Just cut off the ligament, the splenic colon ligament and the gastrocolic ligament. This is spleen. Here is the kidney. You can see the kidney. At last, we separated from the lateral peritoneum because the tumor has invaded into it. We do it at last. We also cut off the tumor and do the chronic anastomosis with auxiliary incision. Okay, there's some videos of left and right hand collector. Before I end the presentation, I want to talk about the progress of minimally invasive surgery. In 1985, the first laparoscopic cholecystectomy was performed by the Mr. Mu He. Mu He is sightless, and it has roused fierce criticism. This is not an operation at all, and the operation was investigated by the court. Now, 95% of cholecystectomy underwent by the laparoscopy. In 2000, the first robotic-assisted prostate cancer surgery was performed by Bider, Professor Bider, and also questioned by experts. I doubt whether it's the result of the robotic surgery are worthy of clinical application. But no, 85% of the prostate cancer surgery underwent by the robot surgery only in America. Today, the robot-assisted colectomy also got challenged. Our laparoscopic surgery skills are on the top. Why we do try the robotic surgery? Will history repeat? I'm sure it will, and the robotic surgery may have a promising future. Thank you all.
Thank you, Dr. Engineer. Thank you so much. Perhaps this will repeat, I don't know. We come back in Italy now with the second presentation by Pietro Paolo Bianchi, the robotic right colectomy with the complete mesocolic excision intracorporeal anastomosis.
Good morning. Thank you, Franco. It's a great pleasure, and thank you to Ugo for the invitation, and congrats for the organization of this great meeting, and also to Fulvio Calise for this initiative about updating surgery. Can you please show the slide? Well, I started. Okay, thanks. Today I will present to you our technique about robotic right colectomy with a bottom-to-up approach, a complete mesocolic excision, and an intracorporeal anastomosis. I just start with some technical details to show the operation, and then I will present also our results. We approach with the Da Vinci Xi system, right column suprapubically, and this is the port placement. Usually I prefer to use two left hand. In trocar number 1, I have a grasper. Trocar number 2 and number 4 are the so-called right and left hand. So in trocar number 2, I have a bipolar forceps, and in trocar number 4, a monopolar hook. Usually I like the hook, but even scissor, it depends from the case and from the patient. And one at the trocar, the assistant trocar is placed at the level of the left flank. All the trocar you see are suprapubically, and sometimes the two more lateral trocar can be a little bit higher. It depends on the shape of the patient and the position of the spine. And this is the view that we have in the OR of placement of the trocar. The first step of the procedure is the detachment, posterior detachment of the root of the mesentery, third arm lifting up the cecum and the appendix, and we find out the plane between the posterior sheet of the mesentery and the ascending column and the geroid and the told fascia. This is a very thin patient. Sometimes thin patient can be more difficult rather than obese patient because the plane are very thin, but it's possible to appreciate nicely the shining of the fascia. And the aim of this approach from bottom to up is to maintain the integrity of the posterior fascia of the mesentery, that is the first aim of complete mesocolic excision, and to detach the pedicle of ileocolic vessels from superior mesenteric vein in order to be safe then when we move medially to dissect superior mesenteric vein and the right colic vessels. So we proceed. The hook is a nice instrument, I think very precise for robotic surgery. That is an embryologic surgery following embryologic plane, and with the tip of the hook you can coagulate very nicely. With the back you can dissect your tissue, and so of course the movement, the wristing movement of the instrument is helpful in performing precise dissection. I show you another case, a little bit speed up just for reason of time. Again, this first step, assistant at the table is lifting on the left side of the patient the root of the mesentery, and then we move until we can reach the duodenum and the pancreas, and we can detach, as is much more clear here, the confluence of the ileocolic vein to the superior mesenteric vein. On the left side of the screen, you see the root of the mesentery, the pancreas, the duodenum, and these are our landmark to perform the posterior detachment. Then we move back our right colon in previous position. The third arm is lifting the mesentery, and we can open easily the space to reach the plane that we have prepared before. And so we can move on and going ahead to the dissection of superior mesenteric vein and to lymphoadenectomy at the origin of the vessel. Third arm lifting up the pedicle, the assistant lifting up the mesentery, the transverse mesocolon, and inside your operative field you maintain just your two operating instruments, so bipolar instrument and monopolar hook. This was an extended right colectomy for a cancer of right column flexure, and so we mark, we sign at the line of our dissection at the level of the transverse mesocolon. Here you can see ileocolic vein and ileocolic artery dissected. One of the particularity, I mean, of robotic surgery is to maintain your clearly anatomical plane with a traction and counter traction that is followed maniacally in order to have the exposure of your structure precise and nicely. On the left side, you can see the Henle trunk is coming up to your view, and we follow the plane, the different plane, posterior, mesogastric plane, in order to expose the Henle trunk, as you can see here. This is midocolic artery. This patient, the anatomy of right colon is different from patient to patient. We have transected midocolic artery, and then we move up, opening the gastrocolic ligament in order to be safe to identify the right gastroepiploic vessels, and we mobilize the right colonic flexure with the help of a sealing instrument. Then we're coming back to our vessels. We are now safe on the control from upward and downward of the Henle trunk, and we can proceed and going ahead with our vascular dissection. This is the superior right colic vein, that is the vessels that maintain the two plane together, and the last vessel we have to transect in this patient is the midocolic vein that is clearly seen here. And so this our vascular dissection in this case is completed. Again, another short video. Here the posterior detachment has already been done, and this is the view that you have from a bottom to up approach with a suprapubic trocar position. You have in front of you the superior mesenteric vessels and the axis exactly in front of you, and so you can follow the landmark of your superior mesenteric vein, and so you can dissect the anterior surface, expose the anterior surface of superior mesenteric vein. Again, the utility of the hook in order to obtain this kind of vascular dissection in an anatomical region that can be very different, as I talked before, from patient to patient, and also sometimes can be dangerous. In this case, ileocolic vein and ileocolic artery were cut together because they were tight, and then we move, maintaining the integrity of the fascia. The concept of CME is maintaining the integrity, trying to avoid any disruption of your anterior and posterior fascia. Pancreas on the left side, and then in this case we have a right colic artery that is coming below the superior mesenteric vein, so right colic artery is isolated and transected. The assistant is helping with traction and counter traction, exposure, and good vision. These are the principle of all the surgery, of course, but particularly of robotic surgery. Again, the helmet trunk, clearly view from bottom to up. I think particularly for colorectal surgery is much easy to have this kind of anatomy with superior right colic, pancreatic vein, the right colic vein as we've seen before, and the right branch of middle colic artery. Here the transection of the artery is performed with the robotic lip applier. That is a good instrument because you can reach a nice angle, and you can put your clip in a correct position. And then we proceed with a complete detachment of the root of the mesentery, maintaining again the integrity of our fascia. Again, helmet trunk, right gastroepiploic, superior right colic vein, and anterior pancreatic duodenic vein, clearly seen, and transection of superior right colic vein. That is the only branch of our helmet trunk that we need to cut. Again, with the use and the help of robotic lip applier. In this case, we perform also a lymphadenectomy at the level of the left branch of middle colic to complete D3 lymphadenectomy, high vascular ligation, CME, and extended lymphadenectomy are the principle we are following. The anastomosis, also the title of presentation was intracorporeal anastomosis. Anastomosis is side-to-side iliocolonic anastomosis. This is a robotic stapler, a 60 blue cartridge robotic stapler transecting the colon with the help of ICG. And the same stapler is used to transect the ileum. Is moved the stapler by the operator, him or herself. The movements are wide, and the position of the stapler is the right position of the stapler is easily reached. In this case, we have a very small bleeding at the level of the colonic stump, intracorporeal suture of the robot. We have seen fantastic suture from Ugo before. Is easy to be performed, so even control small bleeding and suturing intracorporeally is helpful with the movement of the instrument. And the next step is the anastomosis. A small hole is created at the level of the transverse colon and another one at the level of the last ileum. And again, with the robotic stapler, we perform the side-to-side anastomosis. We use, as we learn from Giuseppe Spinoglio many years ago, to put the thicker part of the stapler in the ileum and the thinner part in the colon to avoid spillage of stool material inside the abdomen, and the anastomosis and the stapler then is fired and the anastomosis is completed. So the last thing we have to do is to close the two small holes where we have introduced our stapler. Usually I perform a suture with a double running suture using now a barbed suture, but with the robot you can use also not a barbed suture. It depends from your preference. The first stitch is placed at the level of the inferior corner of the small defect we have on the colon and on the ileum. And then we put another stitch on the upper corner, and we perform the two double running suture. Of course, this kind of suture is easy with the robot. Is also a step of the procedure that can be used to train and also to start with the young surgeon to take confidence with the robotic arms and with the intracorporeal suture. This is our way to close, but of course you can use just one running suture or coming up and down with the same stitch. With this kind of suture, we are fine. Usually after a complete mesocolic excision, the defect of the meso is wide, and so I prefer to close even the meso with some separated stitches to avoid, of course, in the post-operative course, any obstruction. It's possible to clear the peritoneum to avoid any hematoma at the level of the peritoneum. 2 or 3 stitches are enough to close our defect and to avoid the bowel get inside the wide defect. And this is the final result of a side-to-side anastomosis after a robotic right colectomy. What we have to reach, of course, independently from the technique you use, robotic laparoscopic open technique, is this. So you need to have the mesentery and the meso completely not disrupted in the anterior surface, in the posterior surface. You have to measure the distance from the vessel ligature, from the stump of the iliocolonic vessels, and the area of your specimen. Very quickly, we publish on the issue of updating surgery our result in 161 patients which underwent a robotic right colectomy, and these are the baseline characteristics of our patient. Some operative outcomes, just one point about the conversion rate was 3.7%, 6 patients on 161, and all the patients were converted because oncological reasons. So where a huge tumor, of course, more you use the robot and more you want to use it. And so these were advanced cases where we need to convert to open surgery to decide if to perform more extended resection or pancreatic resection. About postoperative outcomes, acceptable. The length of hospital stays were near to 5 days, 4.9 days. And even the complication, post-operative complication were 60% with a percentage of high degree, 3-4 degree Clavian did 6 patients on 161. And also from an oncologic point of view, with a median follow-up of 31 months, we reach acceptable result comparable with the standard technique of disease-free survival rate and also overall survival rate, even in the curves we evaluate from stage to stage. So to summarize, the CME, vascular ligation, high vascular ligation, deep lymphadenectomy, right colonic surgery is a challenging surgery. Anatomy can be different from patient to patient, and surgeon need to know anatomy to know before even also the operation with the good CT scan, and to follow embryologic plane to perform a precision surgery. In my opinion, the robotic platform is helpful to reach a minimal invasive treatment with this kind of extended procedure. There is not a standard right colectomy. The main advantages, of course, are technical, and you have seen in this short video which were the technical advantages that we reach with the robotic platform: a good exposure, good vision, dissection clearly and safely done with the precise instrument and with the movement on the instrument, extended the lymphadenectomy, and also intracorporeal anastomosis can be done with robotic stapler and with the easy suturing of intracorporeal suturing with the movement on the instrument. And naturalmente, last but not least, the safety in our experience, oncology safety is rich. Of course, we need more study, more comparative study with more evidence to confirm this kind of result. Thank you so much for your attention.
Thank you so much, Paolo. I agree with you that the right hemicolectomy could be the good option for the robotic approach, more than the left one. We discuss at the end if we will have the time, and now we leave the colon and we go down to the rectal surgery. For technical problem, we are not connected with Dr. Parvez, but we recorded his presentation Please, can you send the presentation of Dr. Parvez?
Hello, good morning. Thank you very much for the very kind invitation. My special thanks are due to Professor Boggi for very kind invitation to join my Italian colleagues and international audience by and large, and for Barbara for persistently chasing me to send all the paperwork and the presentation. The subject today for me is to discuss a role of robotic rectal surgery as a state-of-the-art lecture, but I thought it's worth focusing on what I describe as marginal gains that robotic surgery offers for minimally invasive rectal cancer surgeons, and perhaps look into it, that are they worth the pain? Some of you might know me. My name is Amjad Parvez. I am a colorectal surgeon who has interest in minimally invasive surgery, including robotics, of course. And I'm currently a director of European Academy of Robotic Colorectal Surgery with a few other roles that I do worldwide. This is one such place, which is in Lisbon, Portugal. This is Chimpelemo Foundation. I have been associated with this wonderful institution since 2014, a state-of-the-art institution offering rectal cancer surgery and rectal cancer care effectively. You're very welcome to come and visit us anytime when pandemic and weather permit, of course. So how has rectal cancer surgery evolved over a period of time? We know now for sure that total mesorectal excision as a concept have significantly impacted the local recurrence rate and hence the survival in the last few decades. Introducing stapler obviously increased the splinter preservation rate over a period of time. And then a couple of decades ago, the concept of performing extra-elevator abdominal perineal resection and avoiding specimen wasting and perforation resulted into better specimen and perhaps better local control of the disease for patients requiring abdominal perineal excisions. We know now that minimally invasive surgery done either through laparoscopy or for that matter robot does have better short-term outcome with equivalent oncology. And more recently, introduction of robotic systems have begin to show that there may be a marginal benefit associated with using this particular technique. We know this over a period of time now that this debate have been put to rest, that MIS surgery does offer better short-term outcome for colon and rectal cancer surgery. No difference in oncological outcome have been reported, although our open surgical colleagues for decades have really pushed us to show that advantage conferred to laparoscopy. But my argument remained that why it should be any different, because the biology of the cancer has not changed. The tool have changed, anatomy has not changed. And I think this is the key to remember when we embrace any new technology. So much so now that in United Kingdom, where I live and practice largely, the standard of care, like most of the Western Hemisphere, for colon and rectal cancer have become MIS surgery. So if you cannot offer this to your patient as a first mode of intervention, the patient moves, and with patient, the money moves. What does robotic surgery offer? Obviously, if you do things precisely, you are likely to have better short-term outcome at least. We know now through various literatures of meta-analysis, personal series, published evidence that there is a definite advantage of low conversion rate to open surgery when you compare laparoscopy with robotics in particular. It does have a role for an area of interest. In our specialty, the area of interest is a narrow male pelvis, perhaps. And if you do things precisely and you have a better tool to complete your task, the likelihood is that you would have less collateral damage. And the data in some centers have begun to show that you perhaps have better urogenital nerve preservation function. And all of this can result into what I call better short-term outcome in specific subset of patients, the high-risk patients. If you look at ROLAR trial with more inquisitiveness, you would show that you would see that perhaps in subgroup of patients, they begin to show better better short-term outcomes, particularly for conversion in obese patient, mid-low rectal cancer, post-radiotherapy patient. Being somebody who's interested in teaching and training, I think this is an excellent platform, an excellent tool to train surgeons and make standardization a thing that we all aspire to do. This is a slightly older slide, but this is a HAS data from England showing mode of laparoscopy for elective colon and rectal cancer. This is self-reported data, remember, and we are hovering around 60 to 70% with obviously 10% conversion rate. Remember, this is both for colon and rectum. And if you take rectal cancer out of the data, the conversion rate goes up and the intervention falls to about 50%. So rectum is a bit different than colon. I train people around the world. I am often asked to look at specimens and look at people's quality of work. This is one such specimen, one such picture of the patient sent to me through one of the trainees who performed, one of the surgeons, in fact, who performed a laparoscopic abdominal cranial resection. And he was very proud and he wanted me to have a look at it to say, we can do the same operation as the robot does, even with laparoscopy. And by looking at this picture, most of you would agree that perhaps all looks okay, except perhaps the stoma is a bit lateral. The rest of the holes are where they should be. So I asked them to send me the picture of a specimen because I genuinely believe that's where the quality of standard sits. And you would agree with me that perhaps this specimen is slightly suboptimal, particularly if you're a cancer surgeon. So the aim really is to focus on delivering high quality cancer care and use the tool as mere tools, not as a religion, as in other words. So if you are changing to robotics, you change to robotics for the right reason, that you are likely to do a better job of your minimally invasive surgery, likely to respect the specimen, produce better specimens. What really matters to patients? They obviously want to come into hospital, leave hospital without cancer and without complication, of course. They are no longer interested in living longer alone, but they want to live better. I think this is where the nerve preservation and the function preservation would play a key role. If you compare both, obviously it costs more. If the debate is around the cost, then we can just stop this debate now, because at the moment it does cost more. Gains are in clinical outcome. They may be marginal, but they are definitely. Improvement needs purposeful practice. Better conversion rate are associated with robotic surgery. Better urogenital function, certainly in our data that we have shown, and some high-risk patients that I would share the data with. These are challenges of TME surgery, full stop. You know, I put laparoscopy there because there's a direct comparison of robot with laparoscopy. Exposure become a problem, energy source, radiotherapy adds to the difficulty, male patient, stapling very low, and of course the published evidence stop us. These are two such trials. You are well versed with this. This is an American study comparing laparoscopic and open surgery quality of specimen data, showing that laparoscopy specimens were slightly inferior to open surgery, published in JAMA. Interestingly, despite having some eminent name on the paper, the rectal perforation rate in laparoscopic arm is 15.5%, which is quite high. If this would be the case as a rectal cancer surgeon in our institution, I would be stopped doing minimally invasive surgery if I have such a high perforation rate for the specimen. This begs the question of the volume of practice and perhaps the skill set of the people who are contributing within the trial. Similar trial from Australia, a la carte study showing exactly the same thing. So there is a question mark raised for rectal cancer surgery, even after 2 decades of doing laparoscopic TMEs. So what can robot improve? I keep referring back to the marginal gains, that is true, but to me, anatomy holds a key. If you could reproduce an anatomical operation with a 3D angulated instrument, you are likely to have better short-term outcome. And then because of this, it may result into better long-term survival, as some of the data have started filtering through. Skill acquisition have to be done through structured and standardized training. So it does offer advantages, but with a pretext. The pretext is it has to be learned properly, it has to be practiced properly, and it has to be analyzed and scrutinized properly, just like any other new technique. This is our paper, published a while back now. Jamil Ahmed wrote this with me. This is a technique of doing a totally robotic procedure using an SI system. Initially, there was a problem with splenic flexure mobilization, and the robotic system being very heavy. Patients can't move before the arrival of table motion, and people were doing hybrid techniques where they will mobilize the flexure laparoscopically and the vessel laparoscopically and dock the arm for the pelvic part. We followed Sohan Kim, who did this flip arm technique, showing the same thing, that this can be achieved robotically. And even within the robotic modules, as I call them, we try to standardize each step. I alluded to the fact that there was a problem with splenic flexure mobilization because we, as a colorectal surgeon, certainly in England where I work, we are not very comfortable working over the pancreas from below, and hence the problem was. So we standardize the technique, standardize each module of our surgery, and try to publish it in a way where people can be taught the same way. What is our data? This is our data comparing laparoscopy and robotic rectal cancer surgery, comparing both arms directly, male and female, showing better nerve preservation rate in male patients for robotic arm. Now, we have to be careful analyzing small series of sexually active male. Also, all the assessment tool we use for urogenital function are subjective, which mean IPSS score, and men tend to rate themselves quite high when asked about their sexual performance, so to speak. So perhaps an objective view of measuring this would be running another trial, which is called UROL trial, which is currently being going through the process of implementing and recruiting patients where the residual urine volume would be measured with urometry. We looked at our patients, obese patients, compare our laparoscopic data with our robotic data, which showed better short-term outcomes. Short-term outcomes, largely complications. Complication requiring prolonged length of stay, re-intervention was much shorter in our robotic group, and hence the length of stay was shorter. This is a high-risk group paper that I referred to. This is a group which is a BMI of 30 or above, male gender with mid to low rectal cancer, people who had downstaging for locally advanced tumor below the peritoneal reflection, and previous colonic surgery. Although it was not randomized study, but you could see both group match quite efficiently, no difference in terms of their patient demographics or case selection. And this data or paper showed that robotic arm was associated with higher preservation of sphincter function, reduced blood loss, better conversion rate, of course. Shorter operating time is an anomaly because robotic surgery was done by the consultant surgeons from start to finish, while laparoscopy was performed in modules for supervised trainees doing flexure and vessels, and the TME part was done by the consultants. Because they had less morbidity, they had a shorter length of stay in robotic arm too. This is Sohan Kim data, excellent paper published a while back now. He's an excellent laparoscopic surgeon. He compared his own data of doing robotic with lap, and you could see that they are propensity match score, which showed there is an advantage on univariate and multivariate analysis independently in favor of robot for people who would undergo robotic rectal resection, even in his hand. Okay, given it's a single center yet, not many people have reproduced this, but this is something that we have to look very carefully. All of these gains are linked with learning it properly. I keep coming back to the same thing. Standardization and structured training would result into better outcome. I think this is something that we have to focus as a profession within Europe and beyond. We have worked very hard through European Academy of Robotic Colorectal Surgery. Some of my Italian colleagues have helped me do this. This is a European consensus that we had on standardizing the operative technique first, to see that how this would be done and how this would be taught. The idea was this, that we would have an academy within Europe who would train surgeons European-wide, and actually it has gone out of Europe now because we have trainees outside Europe. Currently, 153 surgeons who have registered, 90 cities, 23 countries. The demographics is spread worldwide. This is the data which has been published in surgical endoscopy. We were looking at this study where 35 surgeons who initially completed the training program of assessment and independent practice, they were asked to recruit patients after a sign-off process. 13 European countries, 30 trainees from 21 centers, 7 proctored or trainer also contributed the data as a control arm. So this is just the numbers. You could see the training is the number of cases performed by those 26 trainees under direct supervision of the trainers. Once they graduated the program, they performed 626 cases at their own independently, and 181 cases are the trainer's own data as a control group. And you could see that except for faster operating time in favor of Proctor, a non-clinically significant blood loss of 30 mil versus 50 mil and a day shorter length of stay, the rest of it is absolutely the same, regardless of whoever have performed this. This is T-staging. And then the conclusion with this paper was that if you train people in a very structured and standardized way, they are likely to reproduce the same outcome as the trainers would have. And it is not so much just one step of the operation where you focus on the rectal dissection. It's the whole package. The anatomy is the whole package. For example, this is medial to lateral dissection over the top of Gerota's fascia, done in a very anatomical manner, where embryologically you are separating two layers, one layer from another. This is a very structured, standardized way of teaching people this step. And if people learn this step in a structured way, they are likely to reproduce this step. Marginal gains. What are the marginal gains? The marginal gains obviously are in pelvis. You see on the right side, this is a T2 tumor in a male patient with no radiation, where tissues are nice and soft. You're doing dissection, just going through the Denovellius fascia at a level where you could very precisely see this on the screen left, as it were. There's a slightly obese patient who have post-chemoradiotherapy. You're doing the same step. You know, anatomically, it is so precise that it almost becomes impossible to do it any other way. You just need to have a patience. You just need to follow anatomy. You see on obese picture now, you're dividing the Denovellius fascia from right to left, just saving those neurovascular bundle which comes into the view. You could just see that how this angulated instrument, particularly the male pelvis right side wall, is where the advantages are. And this is something that we need to sort of see. We need to make sure that we see this in all our patients. If we follow anatomy, if we do it in a structured, standardized way, the likelihood is we will have the same outcome. Now the dissection goes under the Denovellius fascia, and you can see how cleanly the package looks. So I think this is something that the robot does confer this advantage, whether we admit it or not. Other thing is the standardization, regardless of where the operation is done. Two different operations done in two different parts of the world, same step you could see very, very similar. Why it should be very different? Because the cancer has not changed, anatomy has not changed. You just need to follow the same principle. The big advantage is this pelvic right side wall, where the instrument can turn backward inside the nerve package, allow you to do this under direct supervision. And the idea is that with this new technology, you would gain marginally important things. You know, a stapling device now available on the robotic console allows you to go as low as possible from above. You have an instrument that can occlude the bowel lumen. You can do the distal washout. This is an obese patient, TME done. You do the distal washout, check with endoscopy, there is no tumor, and then perpendicularly with two stapler firing, you can divide the rectum. Again, very narrow pelvis, but you could see nicely done division from front to back, from 12 to 6 o'clock, showing you a very nice specimen as you would expect it to be. And the idea behind this is that you keep reproducing these specimens because these specimens hold the key for better local control of the disease. And this is something that we as a surgeon can offer to our patients. What else robot can offer? Obviously, robot would be an excellent platform for teaching and training. Any teaching program has to be assessment-based. This is another advantage of adopting robotics now. Now people can remotely mentor. This is a surgeon set in London, supervising a surgeon in Athens. This would come more and more in our practice, and we would see it in our lifetime. Another big technology is this. This is a 5G technology using robotic system remotely without direct wires. This is a work being done in South China, and I'm sure this would come into the play fairly soon. So In conclusion, Mr. Chairman, ladies and gentlemen, I think seeking anatomical precision should be the goal, and robot does offer that at the moment. Standardization of operative technique is key. Attention to details are important. Small things. There is no big one step that would make the outcome different. These are series of small things that you have to do right. Any technique that is good enough should be reproduced. It should be done by other people with the same outcome. The marginal gains do exist, but they exist with purposeful practice. I would finish by saying that only change is eternal, perpetual, and immortal. I'm really grateful for Professor Boggi once again and for my Italian colleagues to ask me to be part of this wonderful meeting. I hope you all stay well and safe, and hopefully we'll be able to see each other in person fairly soon. Thank you once again.
Thank you. Thank you, Dr. Baritz, even if he's not connected with us. So it's impossible to discuss with him at the end of the session. After the surgery, the outcomes, Sergio Alfieri will speak about the oncological outcomes.
Thank you, Mr. Chairman. Thank you, Professor Ugo Boggi. It's an honor and pleasure to be here in this important international meeting of robotics. So thank you. I'm here for 3 reasons. The first one, I said, Professor Boggi organized a very important international meeting. Second, but not second, is under the most important Italian society, the Società Italiana di Chirurgia, the most important and old society in Italy. Our scientific magazine that was organized this Congress, so thank you, Professor Boggi. And last but not least, especially for me today, I'm here for my very old friendship with him, so thank you, Ugo. So he asked me to talk about the oncological outcomes, and I work in a university in Gemelli Hospital, and so I could choose to show you some video, but as my way to demonstrate something is to, like at the university, I see how was demonstrated by scientific. So if we have to validate a new surgical approach or a surgical approach or something new, the ideal framework is that everyone we know that the most important thing in the level evidence and randomized controlled trial for every new surgical approach should guide us. So what do we have? This is what we have today. The American Society of Colon and Rectal Surgery and American Cancer Society write today that open approach is still the gold standard. They also write, I can read very well here. Okay. That laparoscopic colectomy for curable cancer results in equivalent cancer rate survival to open colectomy were performed by experienced surgeons, as well for rectal cancer, and robotic assisted approach remain insufficient evidence to allow meaningful recommendation for colorectal resection using this technique. This is what is written. Okay, but we already saw this morning how many publications we have in robotic colorectal surgery in the last years. And if we look to the robotic, and if we see if the level 1 evidence of a randomized clinical trial, we have just one. So coming back to what Ugo asked me to talk today about the main oncologic standpoints for surgical rectal cancer, I just speak for rectal cancer, we have to look at what we find for every kind of operation, open laparoscopic or robotic, number of harvested lymph nodes, circumferential marginal status, distal marginal status, TM quality, and last but not least, overall and disease-free survival. So if we look at what happened for laparoscopic, I will go very fast for some slides because my friend Amjad is a great surgeon, but he is not very confident with a phone and email. So I ask him to take a chat to not overlap. We have some slides overlap, so I go faster with something he always demonstrate. If we go to laparoscopic, what's happened that oncological outcomes are the same, and we saw before that there are more randomized clinical trials for laparoscopic. No difference. And if we go to the oncological outcome, the inability to establish the non-inferiority. What does it mean, non-inferiority? As a result, for laparoscopic, the inability to establish non-inferiority is not to be considered as a contraindication to laparoscopic approach. I go faster because Amjad already demonstrated that. What's about robotic? Most of people in this room do robotic in his field, liver, pancreas, gastric, colorectal. And we know that is high definition. We see better, 3D imaging vision, favorable ergonomics, 7D movement. We are more relaxed. We see better. We are there. If we can to explain to someone else that don't use robotic, we explain that why we are in open. This is the distance when we make operation. If we are laparoscope, we see here, we see the TV. Like yesterday, we saw soccer play during the dinner with a little screen of our colleague. If we are robotic, we are there in that field. But how to demonstrate that is better? Okay, it's only from the lecture that we see this morning, the first one, because the industry push us to use it. You see the Forbes say that intuitive surgical market cap $15.3 billion with the increasing publication. And you see in Europe is completely red. So, but what about from the scientific point of view? Which kind of all-level evidence? We have many level 2, 3, 4, but just one randomized clinical trial. Let's back to read this paper. And we see that there are 29 centers, 40 surgeons. 40 surgeons. If we consider 237 robotic assisted, we do the mathematics like my kids do, and you divide the number of robotic from 40 surgeons, maybe could happen, I don't know, that of course there are some distinguished colleagues, but maybe some participate with 2 robotic surgeries, 3 robotic surgery in about 3 years. So it's true that is the level 1 of evidence, but the results with 40 surgeons in 3 years are not really give results regarding the pathological results regarding CRM positivity, TM quality, and no data of long-term outcomes. And as you see here, no difference in terms of CRM and mesorectal area. I have to tell you also that reading the paper, there is no description what's the meaning, what's the description of a mesorectal integrity, and no difference in functional. But they conclude that these findings suggest that robotic-assisted laparoscopy, when performed by surgeon with varying experience with robotics, does not confer an advantage in rectal cancer resection. It is the only one randomized clinical trial. I write a letter with my friend Amjad, just we saw before, and we write something that probably there is some problem if you participate with so few cases. So we have to consider that we cannot say that robotic surgery for rectal is not to perform it because the randomized clinical trial said that is not recommended. Then I have not other randomized clinical trial. I have my experience. I have to tell you, I think that if we are invited to speak about something also to show us what we do. And this is my experience between 6 years, published in this magazine. It's about 122 robotic resection, one of the largest experience in Europe, as you see in the table. And you know the increasing number of cases when that you start a program, because the robotic surgery should not be performed. I am sorry, but I'm very direct. It shouldn't be performed in a hospital that the general surgeon, the general manager buy a robotic, and I do one today, one another month, today a liver, tomorrow a pancreas, and another month. There's a program. You should to increase the case. You have to reduce the operating time. You have to reduce the docking time and the blood loss. And you see in this paper my results without the trial. The oncological outcomes, of course, is a personal data, it's not prospective, is comparable to what we have in literature for open laparoscopic, with 90% of overall survival and 83 of disease-free. As far for pathological long-term outcomes, we have a complete of mesorectal excision 94, near complete 4, so it's about 90–80%. With 97% of serum negative, 100% of distal margin by robotic. We just update for this meeting my personal experience is one now until last week 164 better robotic rectal resection with the same results that you saw before. This is Amjad already show us, so very fast because we didn't have not the opportunity to. And this is another paper that I published regarding open versus minimal invasive. Minimal invasive were both robotic and laparoscopic, and then we matched with the propensity score. You see that overall cohort have an advantage in minimal invasive with lymph node and CRM negative, but with the matched cases, no statistical significance. And as well, for metastatic recurrence, some advantage in minimal invasive. Of course, if you do the difference between the cost between laparoscopic and robotic surgery in Italy, not in the world, in Italy, it's more expensive, much more expensive. Ongoing protocol is our prospective multicentric is about robotic versus laparoscopic versus open by functional urinary and sexual problems. We have to enroll 300 patients per arm. We already enrolled 170. This is preliminary results, but very preliminary, so I don't want to share with you because it's not scientifically correct. And my conclusion, very fast because it's late. This is my room. We have one randomized clinical trial that say that there is no demonstration. My hospital spend a lot of money. What do I have to do? Do I have to continue to make a robotic or not? I say yes. I have no scientific evidence today to tell you that I perform 160 procedures of rectal surgery and I do better than robotic, laparoscopic, and open by scientific point of view. I can tell you that when I'm sitting in the robotic, I do rectal surgery, I do better, I see better. My personal results are comparable to laparoscopic open. Of course, we need randomized clinical trial. We need it. Otherwise, we cannot to demonstrate anything. And I also believe that we are working today with robotic in different fields. What we will have also in the future with the digital and other robotic. Thank you.
Thank you, Sergio. Thank you so much. I think that we can spend 5 minutes of coffee break for the discussion. And I would like to share with Paolo Del Rio, who is in Naples.
Hi.
Hi, Paolo.
Do we have some time for the discussion? Do we have 10 minutes or?
Okay.
Okay. So I would like to start with Professor Liu. Can you hear us?
Yes, Mr. Professor Boggi, I'm here.
Can I ask you, what is the rate of robotic colonic resection in your unit compared to the total of cases every year? How much robot do you use?
Oh, thank you, Professor Boggi. I'm a surgeon in the surgical department. We have 7 units. Only in our unit, we can do the robotic surgery. We do about every year 200 cases has been done in our unit, and the other unit almost cannot do with the robot because we have only one robot can be used with our department, although we have about 7, 8 Da Vinci, but only one Da Vinci was used in our department. And totally in our hospital, about more than 1,000 cases has been done a year colorectal cancer, but about 1/5 of this procedure underwent in with robotic surgery. Others mainly do with the laparoscopic surgery. Thank you. Okay, Mr.
Okay, thanks. As Professor Corcione said, maybe the indication for robotic approach to left colectomy is not really ideal, since laparoscopy can do I think a good work and with a lower costs. So if a patient has a simple left tumor, left colonic tumor, do you go straight with robotics or you go with laparoscopy?
That depends. In our country, that also means depends the cost of the surgery, because we can the insurance cannot cover the cost of robotic surgery. So if the patient does not matter the cost, so we usually do it in the robotic surgery. If maybe one surgery more than I think 800 $8,000 more than laparoscopic surgery. So it's the right to choose depends on the patient, not the doctor.
Okay.
Thank you.
On the patient money rather than the doctor.
Yeah, not the doctor, yes.
Is there any question from the floor to Professor?
Yes, I have a question to Paolo Bianchi. Can you explain in 1 minute what are the real advantages of the trocar position that you show us in the vitamin colectomy? The real advantage for the patient, for the surgeons, for the operation.
Yes, thank you, Franco, for the question. One advantage is the vision from bottom to up with your vessels in front of you rather than laterally, and coming to the section posteriorly, you follow an embryological plane existing. When you have to start from medial to lateral, you have to create a new plane, and you have all attached, the anterior and the posterior plane. So this is for anatomical reasons. The other advantage is that if you have an enlarged right colectomy, you can perform easily the anastomosis even on the left side. And this is a great advantage because sometimes when you have the trocar positioned in a lateral to medial, can be much more And the last also from a trauma of the abdominal wall, of course, you have all the trocar outside the abdomen, so can be less traumatic with the post-operative course a little bit better. So these are the main advantages that I found in this kind of.
Thank you. Thank you, Paolo. I have a question for Sergio. Why we continue to speak about experienced surgeon in surgery? It means that we need any time the experienced surgeon in open, laparoscopic, robotic. Why in the paper we continue to explain that for this operation we need, but also for appendectomy we need experienced surgeon?
I agree with you, but what's happened with robotic? That sometimes it was the general manager that buy the robot not for the surgeons, for the hospitals. And what's happened, that because it's happened, of course it's not published, what's happened in the theater when it's happened, that people that are not confident with the mini-invasive or robotic they start to use. This is what I say, that robot does not allow you to do not follow what you are telling. That, of course, if you do in open, you should perform some kind of surgery in experience centers. But we have to be very aware about robotic machine. It's not enough that your hospitals buy today Intuitive, tomorrow Medtronic or Johnson & Johnson to say start to use. And Amjad explained very well that you need a program of proctoring. We have here Professor Spinoglio that can explain us. Change completely the results in terms of complication, mortality, intraoperative damage, and overall disease-free survival. That's why I said, be aware about that.
We have no time to discuss, but this is a very interesting discussion because you are right, but I feel that we need any time this period.
Oh, absolutely. Yes. Yes.
Okay.
If I can...
Ugo, Paolo?
Yes. I think that one of the concepts that Dr. Parvez introduces is that we should democratize surgery. We should offer the option to all patients to have the better treatment, and this could be reached by laparoscopy, by robotics. That seems to have a value in this. But the concept should be that patients should receive the best treatment they can at the most updated and careful treatment, especially in surgical oncology.
To further comment on the concept of the experienced surgeon, one of the advantages, of course it is an indirect advantage, that the see in robotics is to bring back us to think about key concepts like this one. Why you don't need an experienced surgeon in open? You really would like to have a proficient, which is even a little bit better. But now we don't consider anymore for open, maybe even not for lab, but we're back to talking about this for raw. So it is fine. This brings us to a key concept of credentialing of surgeons. We are not everyone is not able to do the same procedure at the same level. What Sergio said is still correct. The roller study provided us probably a biased result because someone was not at that level. So we need to share this concept. We are all surgeons, but whatever we do, open lab, Rob, whatever you do, you must be able to do it. You're not able to do by definition because I myself, you can do whatever I like. You have to do something if you're able to do that. And this will bring the concept of experience out. You are simply a surgeon. A surgeon must be able to do what or she is doing for the patient, So this is a key concept.
Go ahead.
No, because we have to tell the truth.
Good discussion.
Sometimes I laugh because in the last 2-3 years I can read in the paper for the program of the Congress the importance of CME for right colectomy. We show that important speech. I say, but why? When you perform by open or laparoscopy, you did differently? So always the same job. Why now is so popular? My master of surgery teach me 30 years ago that right colectomy should be done with CME. It's not new. So you are completely right.
Thank you. No, microphone. Stay there.
No, I agree with you. But what is still key in lab and in ROG is that people see what you are doing.
Yeah.
When Professor Doglietto was doing what he was doing, you probably were the only one at the operating table who was able to see it. Because when I was assisting my professor, I was holding a retractor, so I was not really seeing. What is key in laparoscopic or robotic surgery is that everybody can see and everybody can learn. And so this is key. This is because some old concept came back, and this improved teaching. You know, if you see a wonderful laparoscopic half colectomy from Franco Corcione, you do understand and you learn. So you see it. If you have eyes, you can see it. Open is a little bit different, you know. Only, I would say, smarter guys understood what was going on. Maybe it was the same. I don't know if you agree, you know, but some people stayed there for years and they didn't see anything. Now, a junior surgeon can walk in an operating room and can see a beautiful anatomy. If he studies, he's smart enough, he can understand. And so it's better for teaching. So minimally invasive surgery improves teaching of all concepts. The concepts are still there, but you can learn it easier and better.
I think that we have to organize a debate in the next Congress between Sergio and Ugo about this topic. Fulvio, the last one.
Well, I am passionate of this discussion, but Professor Parfaitz showed slides and in his experience, the approach, the robotic approach, 10% better oncological outcome after 5 years. Is it true? Do you think you can share this? Because I saw the beautiful video and experience by Pietro Bianchi. How do we approach now? How do you approach? Which is your selection of patients to decide if we go laparoscopic or robotic? Do we need to do all robotics now standing the cost because there is a better oncological outcome? How do we decide what to do? How do you decide which patient should be approached by? This is the question. Otherwise, we don't.
The right question. It's the right question. We want the right answer. So, Paolo, are you there?
Yeah. That's why I asked Professor how many robots. Yeah. So,
you say goodbye.
Thanks, everybody. Thanks to our foreign guests.
Okay. So thank you so much to everybody. I think it was a very interesting session. Enjoy your coffee break. Good morning, everyone. It is an honor for me from Dr. Spinoglio to open this session about the robotic liver surgery. And thank you again, Professor Boggi, for the kind invitation. And thank you, Professor Calise and Professor Basile, for the hard work in the magazine Updating Surgery. We start with the state of the robotic liver surgery from Dr. Liu. We have pre-recorded, I think pre-recorded.
It is that Dr. Liu is not.
We are going to introduce a meta-analysis regarding the state of the art in robotic liver surgery.
We can start, please.
In this presentation, we are going to introduce a meta-analysis regarding the state of the art in robotic liver surgery. Hepatectomy is the most effective treatment modality for patients with liver tumors. Compared to open hepatectomy, laparoscopic hepatectomy has significant advantages, such as lower blood loss, fewer post-operative complications, and shorter hospital stay. Anyway, it has also some shortcomings, such as two-dimensional view, lower degrees of freedom of the instrument, and a long learning curve. So, extensive laparoscopic hepatectomy requires careful measures by experienced surgeons. The Da Vinci robotic system allows to overcome some defects of the traditional laparoscopic technique. Currently, the number of robotic hepatectomies gradually increases, and an international consensus was recently made about this topic. However, there are limited studies on the clinical efficacy of robotic hepatectomy without any confirmatory studies.
Please, can you check
the aim of this study
if you have the audio on the video? No.
In this presentation, we are going to introduce a meta-analysis regarding the state of the art in robotic liver surgery. Hepatectomy is the most effective treatment modality for patients with liver tumors. Compared to open hepatectomy, laparoscopic hepatectomy has significant advantages, such as lower blood loss, fewer post-operative complications, and shorter hospital stay. Anyway, it is also In this presentation, we are going to introduce a meta-analysis regarding the state of the art in robotic liver surgery. Hepatectomy is the most effective treatment modality.
Okay, maybe Professor Cillo, maybe Professor Cillo is here, and we can start with the end of the presentation with Professor Cillo, and then we will see the pre-recorded presentation. Please, Umberto.
Let me spend 1 minute to thank these different kind of activities in pushing up our journal. That has been an incredible enterprise, and I'm really grateful because we really need a platform at an editorial level that is credible, authoritative, and in a way inclusive. So thanks for what you have done so far. Now, I'm trying to, make you a narration of a tentative or conversion of a dream into reality, basically. A dream is the opportunity, the possibility to convert an extremely difficult, demanding, technically kind of operation, which is the oncologically radical resection for perihilar cholangiocarcinoma, into a minimally invasive box, which is something that was, unbelievable until 10 years ago, and probably even today is not still sustainable. Why? I don't know if I can see the images. Okay, thanks. Why this is so difficult? Because if you look at the international literature, as far as minimally invasive approach for perihilar cholangiocarcinoma, speaking purely about, the laparoscopic kind of approach, you can see how we only have anecdotal experiences. We have a couple of experiences in the early 2010, then we have 14 cases in back to 2011 in China, then again 5 cases, 9 cases, 11 cases. And let me draw your attention in this area of the draft here, and also about the next one. For example, this is an Italian experience of laparoscopic approach to perihilar cholangiocarcinoma, showing how in 16 cases, in most of them, the hepatico-jejunostomy was done with an open midline incision. Because clearly, provided that you do not have a very simple single, duct, very easy to expose without inflammation or in a very early tumor, where you can do clearly a laparoscopic anastomosis, but in a complex situation with a difficult field, then it's very difficult to achieve technically demanding procedures as far as reconstruction is concerned. That is why there is a push, relevant push, at least ideally, in the direction of robotics. But if you go back to robotic experience, you see how anecdotic is even in this particular setting. First case done 2010 by Giulianotti, Pisa Surgical School, fantastic visionary kind of procedure, but he didn't follow in any series. He didn't try to, standardize at an evidence level the procedure, and that's one major point. Then a few experiences by China. This is an experience including by Liu, 39 cases, which is a huge amount of cases, if you consider, the difficulties of procedure. But if you go a little bit into the detail of the description, you see how only in 3 cases they did a major hepatectomy. So in most cases, they did just an excision of the tumor, then biliary reconstruction, which is still a nice piece of information from the technical point of view. But clearly, this is not something that you can take and translate in clinical practice, at least in our days. Xu, back in 2016, they did 10 cases. At the end of the day, they concluded that robotic is a failure as far as perihilar cholangiocarcinoma is concerned. Why? Because they had huge blood losses and 90% complication, which is, it was unbearable at that time, at least. And this is something that was. Then, probably the most relevant series, which is this one by Li, again China, again 48 robotic resection. Your attention to morbidity, 60%, which is pretty nice in the context of perihilar cholangiocarcinoma. Look at the radical oncological radicality, 72%, which again is a nice profile, as far as I'm concerned. A little bit perplexity is about the fact that they included 17 cases of Bismuth 4, which is a borderline indication, from the oncological point of view, and even in a very early series, something to discuss about it. And also perplexity about the timing, because they did 500 minutes as maximum, but considering only the console time. But we know how, dispersive is robotic surgery in the interval between the console time. So the time were much longer than this. So very preliminary, not conclusive experience. That's the reason why we wanted to be, totally fascinated to the perspective to do everything laparoscopically, minimally invasively by robotic. We started our robotic program. This is pretty funny. If you look that we had a very, very short experience in robotics. We had our machine dedicated to general surgery. I don't know your reality in Italy or in anywhere in China. Since late 2018, we had the opportunity to operate on just for 8 months because of COVID, pandemic. So clearly robotic was stopped at that time. And so in this 8 time, we had to, include all the cases where were possible. We did 30 cases, only 30 cases, resections. We choose deliberately to include relatively middle-high level complexity resection, 5 major resection, 5 posterior sector, and 3 second one. We had a 13% conversion rate, no mortality, luckily enough. Why? Because we believe that the cost effectiveness of the procedure is justified only if you have a complex procedure. I would say only if you need to have some kind of extraction. Otherwise, you can do laparoscopically very easily, at least in my eyes. Small robotic experience, but in a context, I would say, of relatively large experience in hypermobility surgery. We did 600 laparoscopic procedures with an increase of 37% in last year, reaching close to 140 procedures, laparoscopic procedures per year, speaking about resection per year, and within proportion of cases, close to 50% of the cases done laparoscopic if compared to open surgery, as far as hypermobility surgery is concerned. And the backbone as a message is supposed also to be included as far as cholangiocarcinoma is concerned. We do basically 100 procedures for biliary malignancies per year. And this is the backbone that is needed, to my eyes, in order to step into a relatively small experience in robotics. So that's the reason why we tested, and we try to standardize in a small series, which is actually the very first Western series. We did only 4 cases, but the other Western series were only single case reports, and this is the first tentative to standardize, to give you, details as technical point of view is concerned. Just going very quickly to the selection criteria, we choose only left hepatectomy, at least preoperatively, in order not to increase the complexity of the procedure. Then we excluded vascular invasion at radiology, we excluded upper abdominal surgery, previous hilar radiotherapy, and of course, cirrhosis diagnosed preoperatively was excluded. In the middle of our experience, we also excluded obese patients because of complexity of positioning and managing of everything, trocar and so on. And so we also excluded relevant anatomic variation in order to ease the very first learning curve of our phase. And we did all Bismuth 3B cases. All patients were stented before surgery. A few got preoperative cholangitis and chemotherapy, as you can see here, and going very fast, interestingly enough. In most cases, we have more than one duct to reconstruct, and this is the strength of robotic approach in this set. As you see, 2 anastomosis, 3 ducts, even 5 ducts, and you will see in the movie in a minute. How about results? I think are relatively encouraging, clearly not definitive. This is just anecdotal again, but we need to start from somewhere. We had no more than 3 dendoclavian complications, so no severe complication, 1 ileus, 1 biliary leak, 1 asymptomatic debris on segment 5, relatively short postoperative stay, lower than 7 days in most cases, and then oncological results, which are 75%, 1 positive proximal margin at the final pathology out of 4, which is 75 R0 resection. The patients are relatively good, only 1 recurrence with a very short follow-up, because again, my experience was located from 2019 to 2020. To get in a context with kind of results, look at these Western experiences about open surgery for perihilar cholangiocarcinoma. Look at that, the yellow line, 78% of R0, close to 75, 72 of the Lee experience. The morbidity was 54% in this series, which is back to 2019, and mortality 13%, 90 days mortality 13%, which is something. Perihilar cholangiocarcinoma, this is a good multicentric kind of experience. So let me go to surgery technique. These are positioning. We wanted to be a little bit in excess in terms of accesses and ports in order to better control a complex field, including lymphadenectomy, resection, and reconstruction. And let me go to the movie in order to comment with you. There is a comment, but I will try to give you more pieces of information on that.
This video shows a case of a 54 years old female patient with a diagnosis of a perihilar cholangiocarcinoma. The patient underwent fully robotic left hepatectomy with tetraductal hepaticojejunostomies. After carefully opening a hepatoduodenal ligament, a peeling of hepatic artery, including a perineurectomy along the course of the vessel, is performed.
So abdominal surgery knows how inflammation is key here. There is a lot of inflammation, difficult to find planes. And this is a fantastic
proper hepatic artery is isolated and spaced from the common bile duct.
The patient had a couple of stents, one stent within, and you can see how big is the common bile.
The common bile duct is isolated, circled, and interrupted. The biliary prosthesis is cut and removed.
It's absolutely fantastic.
Perihilar lymphadenectomy is now completed.
Now, this is something that you could do even laparoscopically, clearly, but the quality of precision that can, warranty to the patient is very high. You can see a small lymph node can be retrieved, collected, sent for frozen pathology, and it depends how long you will, stay on lymphadenectomy, how long you will be, aggressive for that. This is the retrieval of a lymph node which is positioned 12 below and behind the portal vein that you can get in an anterior plane and retrieve very nicely. You can really, if you spend a little bit of time, clean up nicely your hilum. And this is very important, clearly, from the oncological point of view. This is a residual of lymph node that is going to be resected in order to have a better oncologic clearance at that level.
Common bile duct and cystic duct are pulled up in order to expose right and left hepatic artery.
So we try
Hilar dissection proceeds with the portal vein isolation.
The issue here is that to perform close to no touch technique as far as biliary common bile duct is
Hepatic
concerned.
artery is pulled up. The left portal vein is cut between hemolocks.
See how nicely you can approach also behind the artery to the left portal vein. It's something that I'm not sure the laparoscopic acquired.
The left hepatic artery is then interrupted.
Not a classical, neat, clean hilum that you can see, colorectal metastasis operation with cholangiocarcinoma, a lot of inflammation there.
Caudate lobe is now freed from the vena cava, and short hepatic veins are interrupted.
And a fantastic feature of robotic and laparoscopy, I would say, the approach of the caudate lobe from below, which is the best way to see, the accessory veins and to go through, to free up, and in a very safe environment, to my knowledge.
Transaction starts along the Cantley's line using ultrasound and monopolar devices.
A little bit of negative drawbacks, management of, cut and sew phase. I mean, we're waiting for energy devices.
The root of V5 of middle hepatic vein is identified and interrupted with the usage of hemolocks.
We developed a kind of dissection with this using a monopolar pad.
Parenchymal transaction proceeds.
Endotracision, in order to try to increase your capability to see structures behind.
The ventral part of the hilar plate is exposed to determine the right bile ducts.
Anatomy is a little bit complex, you can see here.
A 3D reconstruction shows the bile duct anatomy. A biliary trifurcation of the anterior bile duct pedicle is evident.
We have anterior and posterior segment 8 bile ducts.
Interruption of anterior bile ducts with white bile leaking.
It's very interesting because all the anterior sector were
A
isolated.
ring-shaped sample of the anterior bile duct is sent for pathology.
Very accurate in sampling. And this is a white bile because of tumor occlusion.
Anterior bile ducts were priorly completely excluded due to tumor compression.
You can see the three.
Exploration of anterior bile ducts.
2 for B8 and 1 for B5. And now we explore the posterior one.
Detection and opening of posterior bile duct.
It is outstanding. course, no cautery there.
The transaction proceeds with the recognition and interruption of the common middle left hepatic trunk.
I have to say we had a little bit of problem here, as you see a number of clips, but at the end of the day we were able to...
The resection is now completed. The final check is done to find the number of ducts to be anastomosed.
The anterior, one posterior. So
the presence of 3 anterior and 1 posterior bile ducts is confirmed.
Really, it's doable. I don't think laparoscopic can achieve.
The first hepatojejunectomy is prepared.
We wanted to fix the loop in order to, with the stay suture, in order to approximate the two, stumps.
A stay stitch is put in the left corner of the posterior right bile duct.
Is a Ugo trick in order to fix the running suture. Thank you, Ugo, for that.
A 5-0 gore running suture is performed starting from the posterior layer.
Look how the magnification gives you the possibility to see the mucosa on both sides. This to me is fascinating. You don't lose any
magnification considerably improves the suture on a 5 mm bile duct.
It's like a big one, but it's not actually. Is the posterior layer?
The anterior layer is performed using another 5-0 gore locked bile laparti in the tail.
So 2 independent stitches, posterior, anterior, both independently fixed with the laparti. And this is the posterior one. In a way, the more complex, or in an open surgery, because it's down below the portal vein, it's a little bit more complex. This is very nice to see, very open.
The anterior anastomosis is now carried out in the same way, including the 3 anterior bile ducts.
We decided to do a bigger hole here in the jejunum in order to include all 3, and to perform again running suture behind and running fit suture in front of the anastomosis.
And the wrist system helps dramatically the stitching in such a tight scenario, mimicking the open surgery setting.
I know if you use to cover forceps in order to protect
the posterior layer suture is locked to the liver in order to maintain tension.
Important to stabilize your suture.
The anterior layer is then performed with the second running stitch.
One more time. But again, the precision is something that you cannot even see unless you have big loops and a nice explosion in open surgery. And emotion also is fantastic. I find it really fascinating. Clearly complex, but with a huge amount of potentials there. Now,
to be finally locked by a laparti and then secured by a knot.
A knot may lose your tension during, the procedure or not, so you maintain it with a laparti, then you knot in order to secure it.
The specimen is finally removed through a phanestoid incision. The patient was discharged in postoperative day 6.
I'm concluding here for reason of time, but there is no conclusion to this. It's the very first part of an exploratory phase. I find it absolutely fascinating, some field that you really want to spend your energy on for the future. Thank you very much for your attention.
Thank you, Professor Cillo. And go ahead for the next presentation. The first state for Dr. Liu.
In this presentation, we are going to introduce a meta-analysis regarding the state of the art in robotic liver surgery. In this presentation, we are going to introduce a meta-analysis regarding the state of the art in robotic liver surgery. Hepatectomy is the most effective treatment modality.
Good morning, ladies and gentlemen. My name is Zhao Zhiming from Chinese PLA General Hospital. This is my honor to be here to share our experience of the advantage of robotic hepatectomy for posterior segments. Usually, the anterior and lateral segments, such as segment 2, 3, 4B, and 5, are easily to access in laparoscopic surgery, and the minor laparoscopic liver resection is confirmed to be a standard practice. However, the posterior and superior segments, including the segment 1, 4A, 7, and 8, are located in the deep and difficult to expose. The International Consensus Meeting of Laparoscopic Liver Resection previously has defined the resection of posterior superior segments as major resection and has incompletely defined risks. Laparoscopic hepatectomy in the posterior hepatic region is technically demanding because of limited surgical exposure, as well as difficulties in controlling the hemorrhage and in acquiring adequate and safe resection margins. The performance of laparoscopic liver resection in this region has been limited to experienced surgeons in high-volume liver centers. To overcome the difficulty of laparoscopic hepatectomy in the PS segments, innovative techniques have been practiced, such as the thoracic diaphragmatic approach and intercostal space approach. However, these approaches may increase the incidence of pulmonary complications and thoracic tumor implantation. Recently, some studies have proved that robotic hepatectomy for PS segments are safe and feasible. However, the technique system of the robotic hepatectomy for PS segments has not established. In 2018, the Southampton Consensus Meeting reported that the preoperative outcomes of robotic and laparoscopic resection of posterior segments appear to be similar in terms of blood loss, hospital stay, morbidity, and completeness of resection. This statement is based on the study in 2016, which enrolled 36 robotic and 72 laparoscopic resection of the PS segments, and nearly 50% of them were edge resection. Based on the literature research of robotic and laparoscopic hepatectomy, together with our single-center experience, we established an integrated technique system of the robotic hepatectomy for PS segments. We also published our paper about the robotic resection recently. Since the mobilization and exposure of PS segments in the first step of operation and the key to successful resection, the trocar placement is crucial. These are the trocar placements for robotic caudate lobe in our center. When performing the robotic hepatectomy for segments 4A, 7, and 8, we usually move the trocar of the first robotic arm and assistant portal upward to facilitate the access of the posterior superior region. Through this trocar placement, good exposure of the PS segment could be achieved via the intraperitoneal approach. Besides, in robotic surgical system, The tip of ultrasonic scalpel is not flexible and could not take advantage of the underwidth technology. By the third robotic arm, the right lever could be stably retracted toward left front direction, and the right lever could be adequately mobilized by multi-degree of freedom electronic hook in the first arm. Then placed in the first arm, the ultrasonic scalpel could stay along with the parenchymal resection line. This is a video sample of segment 7 resection. The Gleason pedicle of segment 7 was identified and transected, and then the ICG Florence are very useful for understanding the ischemic segment. This is a video sample of precious suture of opening of hepatic vein. Joint hemangioma of segment 8 could be safely enucleated by the robotic, and the right and middle hepatic vein could be preserved with delicate resection by ultrasonic scalpel. Up to January 2020, we have accomplished 100 cases of robotic hepatectomy for the PS segments, which were the largest single center reported worldwide. There was no open conversion, and the Arling resection rate was 100%. Among them, 33 cases are segmentectomy. The median operation time was 160 minutes. Intraoperative blood loss was 100 milliliters. Post-operative hospital stay was 5 days, and the severe complication rate was only 3.77%. When we perform the robotic caudate lobectomy, we should choose the approach based on the location, size, and diagnosis of lesion. Usually, when we need to transect the liver parenchymal in the ventral approach, we use a middle approach. When we choose the dorsal approach, the right, left, and bilateral approach could be applied. These are the approaches for robotic caudate lobectomy. This is the video sample of total caudate lobe resection for hepatic. We perform the left side approach to resect the hepatic anocosis. Caution should be taken to prevent the injury of capsule. The flexible and delicate instruments facilitates the safe and efficient resection. During the dissection of the dorsal part, the haptic vein is crucial and often leads to hemorrhage. Conventional laparoscopic is associated with a great challenge in this step, which is one of the most common reasons for conversion. We found that stable retraction of the third robotic arm and enlarged 3D-dimensional view could more easily and clearly reveal the dorsal side of the haptic vein. In case of haptic vein hemorrhage during liver parenchymal dissection, precious suture can be performed. This is the sample of the pericaval portion of caudate lobe resection for FNH with the middle approach. From January 2018 to November 2019, 7 patients successfully underwent the robotic anatomic isolated caudate lobectomy with a left side approach without conversion to and without severe complication. This technique is safe and feasible for selected patients. And up to January 2020, we have accomplished 32 cases of robotic hepatectomy for the caudate lobe, which is also the largest single center reported worldwide. This study confirmed that robotic isolated partial and complete caudate lobectomy is safe and feasible. Thanks for your time.
Okay, we pass our first video from Dr. Liu, please. Thank you. And we start a discussion, Professor.
In this presentation, we are going to introduce a meta-analysis regarding the state of the art in robotic liver surgery. Hepatectomy is the most effective treatment modality for patients with liver tumors. Compared to open hepatectomy, laparoscopic hepatectomy has significant advantages, such as lower blood loss, fewer post-operative complications, and shorter hospital stay. Anyway, it has also some shortcomings, such as two-dimensional view, lower degrees of freedom of the instrument, and a long learning curve. So, extensive laparoscopic hepatectomy requires careful measures by experienced surgeons. The Vinci Robotic System allows to overcome some defects of the traditional laparoscopic technique. Currently, the number of robotic hepatectomies gradually increases, and an international consensus was recently made about this topic. However, there are limited studies on the clinical efficacy of robotic hepatectomy without any confirmatory studies. The aim of this study was to perform a meta-analysis concerning a comparison of robotic hepatectomy with open and laparoscopic hepatectomy in order to determine the perioperative efficacy of robotic hepatectomy. The search terms used for the meta-analysis were robotic or robot, and liver or hepatic, or hepatocellular, or hepatobiliary, or hepatectomy, or sectionectomy on PubMed, Embase, and Cochrane Library until March 2020. The inclusion criteria were benign or malignant liver tumors, studies that compared robotic hepatectomy with open or laparoscopic hepatectomy, and reporting at least one of the following outcomes: operation time, intraoperative blood loss, rate of blood transfusion, rate of conversion to open, complications and length of hospitalization. To note that if more studies overlapped population, only the most recent or the most informative was selected. The exclusion criteria were case report or reviews, or meta-analysis, or letters or editorials, non-English studies and non-comparative studies, and studies without separate results for each intervention. Data were independently extracted by 2 researchers and included first author, year of publication, country, year of enrollment, and type of study, and the outcomes of interest. The Newcastle-Ottawa scale was used to evaluate the quality of non-randomized controlled trials. Studies with a NOS score greater or equal to 6 were considered to be of high quality. Regarding the statistical methods, the odd ratio was calculated for dichotomous data, while the weighted mean difference was calculated for continuous data. Cumulative meta-analyses were performed to evaluate the stability of the effect sizes. When I squared resulted superior than 50%, a random effect model was used. If not, a fixed effect model was used. Funnel plots and Harbord and Agar tests were used to detect publication bias. Regarding the results, starting from 1,262 records, only 31 studies were included in the meta-analysis. For a total of 2,999 patients, 1,240 robotic, 1,010 laparoscopic, and 740 open. The operative time was statistically significantly longer for robotic hepatectomy than for both laparoscopic and open hepatectomy, as you can see from these forest plots. The blood loss was statistically significantly lower for robotic hepatectomy than open hepatectomy, but was higher than laparoscopic hepatectomy. The blood transfusion rate was statistically significantly lower for robotic hepatectomy than open hepatectomy. No differences were noted between robotic and laparoscopic hepatectomy. So there were no differences between the robotic group and both the other 2 groups regarding the rate of usage of Pringle maneuver. Regarding conversion rate, no differences were noted between the laparoscopic and the robotic group, but considering only the last years, there was a trend to higher conversion rate for laparoscopic hepatectomy. The length of stay was significantly shorter in the robotic group than the open group, while there wasn't any difference between the robotic and the laparoscopic groups. Post-operative complication rate was similar between the robotic, laparoscopic, and open group. It was the same for severe post-operative complications between robotic and laparoscopic hepatectomy, while the robotic groups developed a lower rate with respect to the open group. There were no differences between robotic versus open and robotic versus laparoscopic hepatectomy for bile leak rate 2. Important to note that high publication bias was observed for blood loss and complication rate in the comparison between robotic and open hepatectomy, and for operation time in the comparison of robotic and laparoscopic hepatectomy. Instead, no differences in terms of results were noted after the exclusion of the sham study due to its high heterogeneity for the comparison between robotic and open hepatectomy. On the other hand, it was not possible to reduce the heterogeneity concerning the operative time in the comparison between robotic and laparoscopic hepatectomy, so the results for this parameter may be unstable. This study has some limitations. There are no prospective studies regarding this topic, so the current meta-analysis was based only on retrospective studies. Moreover, there was heterogeneity in data of operative time. Finally, there was insufficient information regarding long-term outcomes, especially important for malignant tumors. In conclusion, this meta-analysis showed that the operation time is one of the shortcomings of robotic hepatectomy. Anyway, both robotic and laparoscopic hepatectomy are safe and feasible. Moreover, they are comparable in terms of perioperative clinical efficacy and superior than open hepatectomy. To note that robotic hepatectomy is still in an exploratory and development phase, large randomized controlled studies are required in future to provide a high level of evidence.
Thank you. We open the discussion with Professor Cillo, I think also Professor Cillo, and the floor. Are there some comments or questions for the floor? Yes, Dr. Scuderi.
First of all, congrats to everyone. I have a technical question because until 3-4 years ago, I remember that during the session for robotic liver surgery, we always ask, okay, we have not the ultrasonic aspirator for the transection of the parenchyma. And we hope that the industry start with the developing of this kind of transection device also for the robotic platform. But now it seems that we don't need more this kind of transection because I see your section that you use only monopolar and bipolar coagulation or harmonic scalpel and so on. This is my question. Thanks.
No, the point is the opposite around, and this is something that I wanted to ask also to Professor Zhao, because that is a key point of the limitation of robotic approach. You can do it if you well project your operation or to have the direction of one of the trocars that you can use in terms of a straight transection line, to my knowledge. And then you can use ultracision in order to proceed in the same direction and dissect as we do in open surgery or laparoscopic with ultracision. But there is a limitation in turning around the structures, and the question was for Professor Zhao, how it comes. It can clearly change the position in order to go around, but there is a major limitation. So we developed a sort of, expedient in order to, overcome this. And I think the monopolar dissection, as you do with the monopolar dissection when you are in a hurry in open surgery, is a nice way to dissect, to find out the structure, and then you can use also precision, but you can even go just with a monopolar dissection if you are well experienced in open surgery, I guess. But it is something that needed to be done. You know why it's not doable? Because the liver surgery is so small as a market that probably they don't have any revenues of that.
Thank you. Other question for the floor? Professor Calise, please.
Well, bravo, Umberto. But I'm surprised that you chose 3B, because personally, I think maybe a right hepatectomy is even more easy than left hepatectomy with the caudate lobe. I wonder, this is just a matter of casualty, or it's just that you want to start because you run maybe in one suture on the left and not on the right, where you had to do so many sutures. So I wonder, you think it's feasible? I mean, or was just an hazard?
No, I mean, it's a good point. I never thought about that. In my eyes, a left hepatectomy, even including caudate, because caudate lobectomy is very easy, absolutely fantastic in robotic and laparoscopic, is easier and less time consuming than right hepatectomy. But it's in my hands, probably it's the opposite route. That's the reason why I choose what I consider the simplest. And that's the reason. And if you consider that we spend a lot of time at the console, because of the lack of experience in robotic, was limited. And the next step is to compress, a little bit more the timing at the console. So, but the reason was just, the perception that for our hands, the left hepatectomy was easier. But clearly, everything is doable.
Thank you, Umberto. I have a small question for you. Congratulations for the excellent presentation, as usual. As you know, perihalar is very demanding also in open. What do you think about the learning curve, about this kind of tumor for robotic approach, in particular for robotic approach?
No, exactly, that's the point, Fabrizio. What was fascinating to me, that even though with a small robotic experience, but based on I would say, huge experience in open surgery for perihilar, it was easy, to do the step. But clearly, you need to have massive experiences in order to understand the structures, to move in the phlogosis, in inflammatory kind of environment, try to find the structures. You don't have to step on perihilar cholangiocarcinoma. To my knowledge, this is the most demanding, most difficult operation in epidural surgery, including transplantation. I don't know if you agree with that.
Absolutely. Totally agree.
More. So it's a proficiency kind of level, but you need to have a lot of experiences on your background, to my knowledge.
Other question? Okay, thank you very much, and thank you also, Professor Boggi, for kind invitation, and thank you, Professor Basile, Professor Calise, for the Abdominal Surgery, for the magazine, and for the special issue. It's a great work. Thank you very much.
Good morning to everybody. We start the session on robotics in gastric surgery. Let me say a couple of words to thank you again, Professor Calise, Professor Boggi, and the President of the Italian Society of Surgery for organizing this excellent meeting. The first presentation is a video, and I don't know if we have yet a connection. The video is ready to be shown. The video by Professor Kim, South Korea. Okay. Ricardo, do you want to see something?
Yeah, many thanks, Ugo. Great job. It's nice to see all this super technological environment. And thank you, Fulvio, and thank you, Francesco, for having dedicated a number of updates in surgery. So please, Professor Kim, I see you there. Go on with your presentation. Thank you very much for being with us.
Very much for giving me this great opportunity. I'm Yumin Kim of Yonsei University in Korea. In this presentation, I would like to present current status of robotic gastrectomy for gastric cancer, comparison with the laparoscopic gastrectomy from East Asia experience. Radical gastrectomy with systemic lymph node dissection is the core of curative treatment for most gastric cancer patients. Over the last 3 decades, surgeons increasingly adopted laparoscopic surgery for gastric cancer because of its better short-term outcomes. Despite of the high interest, the initial adoption of laparoscopic gastrectomy was rather slow because of a lack of evidence of long-term survival outcomes and concerns about the oncological relevance of surgical resections. The results of robust trials demonstrated the oncological safety of laparoscopic gastrectomy compared with open gastrectomy by proving non-inferiority in survival. However, since laparoscopic gastrectomy is technically demanding operation with a steep learning curve, it is still not widely and easily performed. To overcome the limitations of laparoscopic gastrectomy, the application of robotics for gastric cancer was an expected situation, as in other surgical oncological fields such as prostate, kidney, pancreas, endocrine, and colorectal surgeries. Robotics provide magnified three-dimensional imagery under a stable camera platform, enhanced manual dexterity, and endo-wrist instrumentation under controlling with tremor filtration. These benefits result in a less stiff learning curve and more ergonomic to surgeons. But the efficacy and safety of robotic application for gastric cancer are not fully assessed because of most of the studies are retrospective case-matched series with very few non-randomized prospective studies. So in this presentation, I review details of indications and current evidence for robotic gastrectomy for gastric cancer regarding surgical post-operative and oncological outcomes. The indication for robotic gastrectomy in gastric cancer is not much different from indication of laparoscopic gastrectomy because the approach to the surgical site is the same and there are only differences in the instruments. Indications for laparoscopic gastrectomy have been expanded along with the evidence from the clinical trials. But estimated blood loss is significantly less for robotic surgery than for laparoscopic surgery, and this is a consistent finding in most of the studies. The reduction of the blood loss was more prominent when surgery is challenging, such as in a case of D2 lymph node dissection or patients with high BMI. With the delicate manipulations of small vessels with fine wrist movement of the robotic instruments under 3D imaging, better visibility of the surgical field by less amount of intraoperative blood loss means would result in better quality surgery, but the mean differences in blood loss was not large amount, around 25 cc, and its clinical significance is considered to be limited. Although the difference was relatively low, the possibility of transfusion would be reduced. Thus, reduced intraoperative blood loss is associated with less postoperative infectious complications and is expected to potential reduction in cancer recurrence. Contrary to blood loss, robotic gastrectomy is longer than laparoscopic gastrectomy consistently in most studies. Different from laparoscopy, robotic surgery contains additional time-consuming components that make operation time longer, such as robot docking and setup, instrument change, and camera controlling without instrument movement, or surgical arms by the operator. In a study compared these junk time between robots and laparoscopic gastrectomy revealed 41.5 minutes in difference. Considering the 58 minutes difference in operation time revealed by meta-analysis results, the longer operation time of robotic gastrectomy is mostly associated with additional time-consuming components. Thus, to reduce the operation time of robotic gastrectomy, improving these processes would be required. When bleeding occurs, operation time is inevitably extended to controlling the bleeding and clean up the operation field. Robotic gastrectomy has the potential of being shorter than laparoscopic gastrectomy because robotic gastrectomy has the benefit of less blood loss than laparoscopic gastrectomy. Thus, the operation time of robotic gastrectomy will be shorter or at least similar to that of the laparoscopic gastrectomy if the reduction in duration of additional time-consuming components is achieved with technological developments. There was no significant difference in the conversion to open surgery between robotic and laparoscopic surgery in the studies that compared standard gastrectomies such as distal subtotal or total gastrectomies. Because the conversion in laparoscopic surgery for gastric cancer is very low, the probability of having less conversion in robotic surgery would be very low. However, a recent study revealed that a lower conversion rate in robotic completion total gastrectomy for remnant gastric cancer than in laparoscopy. Although the statistical difference was marginal, it is generally accepted that robotic application is beneficial when performing more complex surgery. Thus, a lower conversion rate in robotic completion total gastrectomy for remnant gastric cancer would be associated with the mechanical advantage of the robotic surgery system. The postoperative recovery-related variables after surgery are usually time to recovery of bowel functions, time to oral intake, and length of hospital stay. In meta-analysis, time to first flat tooth was slightly shorter after robotic than laparoscopic surgery. In comparison, the time to oral intake was significantly faster after robotic surgery. However, post-operative hospital stay was similar between the two groups, although two randomized studies from China reported shorter post-operative hospital stay after robotic surgery than laparoscopic surgery. Because both robotic and laparoscopic gastrectomy use minimally invasive approaches, its operation advantages are the same between the two surgical methods, such as less pain, early recovery, and shorter hospital stay. Moreover, considering the rapid acceptance of enhanced recovery after surgery protocol even after minimally invasive surgery, if the superiority of surgery is assessed using traditional methods such as the difference in length of hospital stay, there will be a few opportunities for robotic gastrectomy to show superiority over laparoscopic gastrectomy. Next, for postoperative complications. A Korean multicenter study reported a very low rate of major complication, around 1% of a robotic gastrectomy. A Japanese multicenter prospective single-arm study reported 2.45% of major complication rate after robotic gastrectomy, and they showed a significant reduction in major complications in robotic gastrectomy compared to laparoscopic gastrectomy. Some studies demonstrated the better quality of peripancreatic or splenic hilar lymph node dissections, but they did not show a reduction in pancreatic complications. Our study especially focused on the incidence of pancreatic complications to assess pancreatic complications using drain and serum amylase, demonstrated a significant difference between robotic and laparoscopic gastrectomy. And the Japanese multicenter prospective single-arm study reported 5.9% of pancreatic complication after robotic gastrectomy. Overall, most studies did not show any advantages of robotic gastrectomy over laparoscopic gastrectomy in postoperative complication. Thus, the advantages of a robotic procedure on postoperative complication might differ according to the type of surgery performed. The exact impact of robotic surgery for gastric cancer on the occurrence of postoperative complications can properly be evaluated through studies of technically demanding procedures with challenging situations such as total gastrectomy with T2 lymph node dissections in obese gastric cancer patients. The short-term oncologic and pathologic outcomes can be evaluated by assessing the status of proximal and distal resected margins and the number of harvest lymph nodes. There was no significant difference between two groups. The number of harvest lymph nodes is not significantly different in any of the meta-analyses. Results of the COAT study are contradictory. Along with the suggestion that robotic gastrectomy may facilitate high-quality lymph node dissection in suprapancreatic and splenic hilar area than laparoscopy, increase in number of harvest lymph nodes in robotic gastrectomy was observed in case of total gastrectomy with spleen preserving splenic hilar lymph node dissections or in patients with high body mass index. Recently, the evidence for oncological safety of laparoscopic gastrectomy for gastric cancer has been demonstrated by many randomized clinical trials. They showed similar results. However, long-term outcome studies included mostly patients with relatively early stages and were from East Asia. Considering the equivalence in the extent of lymph node dissection and its quality, the possibility of having a survivor differences between robotic and laparoscopic gastrectomy would be extremely low. Thus, oncological safety of robotic gastrectomy can be accepted by hiring the oncologic evidence from the randomized clinical trials executed for laparoscopic gastrectomy for gastric cancer, although long-term outcome studies of patients with advanced gastric cancer and from various countries are needed. This is Korean Single Center Yonsei University. The entire COAT analysis revealed no statistically significant differences in 5-year overall survivor or relapse-free survivor, although most of the cases are early period of robotic surgery and for the relatively early cancer. The propensity score matched cohort analysis demonstrated also no statistically significant differences for 5-year overall survival or relapse-free survival. The author concluded that potential technical superiority of robotic system over laparoscopy did not improve oncological outcomes after gastrectomy. Long-term oncological outcomes were not different between robotic gastrectomy and laparoscopic gastrectomy. Nevertheless, robotic application in minimally invasive gastric cancer surgery may be oncologically safe alternatives. This is Japanese prospective single-arm study with clinical stage 1 and 2 gastric cancer patients. The study included 1,208 patients from 2012 to 2020 at a Shizuoka Cancer Center. After propensity score matching, there were 342 patients each in the robotic gastrectomy and laparoscopic gastrectomy groups. Robotic gastrectomy groups was associated with a significantly longer operative time and lower amylase concentration in the drainage fluid on the first post-operative day. And incidence of intra-abdominal infectious complication in the robotic gastrectomy was 4.4%, statistically significantly lower than laparoscopic group, 9.4%. The overall survival of robotic gastrectomy and laparoscopic gastrectomy group was similar. This is China High Volume Center study. Total 1,686 consecutive patients who underwent minimally invasive gastrectomy were enrolled. The robotic gastrectomy group had a significantly higher retrieved lymph nodes number, more retrieved suprapancreatic lymph nodes, and lower estimated blood loss, but longer operation time. The matched cohort analysis demonstrated no statistically significant differences for 3-year overall survival or relapse-free survival. They concluded that robotic gastrectomy has certain technical advantages over laparoscopic group, especially in patients with advanced gastric cancer, but robotic gastrectomy group does not improve long-term oncological outcomes. This is randomized controlled trial study from China, published on the Annals of Surgery in this year. Total 283 patients were enrolled. Robotic distal gastrectomy group exhibited faster post-operative recovery, milder inflammatory responses, and reduced post-operative morbidity. And higher extraperigastric lymph nodes were retrieved in the robotic distal gastrectomy group with lower non-compliance rate. In conclusion, the current evidence from East Asia demonstrates that robotic gastrectomy is safe and oncologically acceptable compared with laparoscopic gastrectomy for gastric cancer. But robotic gastrectomy is argued by its drawbacks of longer operation time and higher cost. Additionally, no evident clinical benefits of robotic gastrectomy compared with laparoscopic gastrectomy might be one of the major barriers of the wide application of robotic gastrectomy. However, even with current evidence, robotic surgery will be adopted more widely as more technological developments are introduced. In terms of evidence-based medicines, robotic gastrectomy requires more persuasive evidence regarding operative and oncological outcomes. Thus, to be accepted more widely in clinical practice, not only overcoming the disadvantages but also clarifying the advantages of robotic gastrectomy is mandated. Thank you for your attention.
Thank you, Dr. Kim. I think we'll take questions and comments at the end of the session. Now, yes, so please, Franco, come over. Franco Roviello from Siena will tell us about robotic-assisted gastrectomy for gastric cancer, results of a Western center. Thank you, Franco.
Ok, grazie. Ok, grazie. Vabbè, ok, grazie. So I think Dr. Kim from Seoul, from Yonsei, he clearly defined very well that there is no difference and no advantages between the use of robotic and laparoscopic approach. So the problem is that they're analyzing the problem from their point of view, where the laparoscopic approach for gastric cancer is the standard, and because more than 70% of their cases are T1, even that one that are reported in the published paper. So we should analyze with a different view, considering our cases and our experience in the Western countries. So we know that the introduction of first robotic case has been performed in 1999 from Uyama and from Per Cristoforo Giulianotti in Grosseto, and already in 2013 with our Italian gastric cancer study group, we have tried to analyze and to define the rules that every surgeon should respect on treating gastric cancer with the minimal invasive approach. Because, as you know, this disease is a fatal and one of the most important prognostic factors is the surgery, as in any other oncologic disease, but in a gastric is more evident. So, and from the analysis of the literature that we have done already in 2013, that was clearly evident that there was a good treatment for early gastric cancer, but there was a kind of needed data for more advanced forms. And still now there is a big lack of literature in this kind of topic. And because of in Western hospital, early gastric represents at least only 10% of the cases. I mean, the training and the learning curve of minimal invasive approach, it's longer than Far East countries. If we consider that about 7,000 cases are operated every year in our country, only 700 are early, that and many times they are discovered only by case. There is a very interesting paper published by Richard von Illesberger from Utrecht Group, and they made a survey, a worldwide survey, just to try to understand how much is the penetrance of use of minimal invasive in gastric, and they see that the distal gastrectomy is also performed not only in the early gastric, but even in advanced. I mean, this is a worldwide, it's not only Western countries are included in this survey. And even if we go through the total gastrectomy treatment, at least between 50 and 30% are performed in minimal invasive. But robotic is still representing a very small percentage of the total treated cases, between 1 and 5% in the centers that, as you can see from the slides, are very wide represented from all over the world, that are performing surgery for gastric cancer. So what is going on in the literature and in the referral centers regarding the trial, as we have the Far East countries like Japan, China, and Korea, where the number of cases are incredibly high and the number of small cancer is incredibly high. So they are trying to understand if there is any results about the feasibility in the advanced cases. Some results are still ongoing. We know from the class performed in Korea that robotic is not inferior to laparoscopic, but as we listened in the from the previous speaker, there is no advantage from this point of view. What happens in Europe? In Europe, we have two important trials. One is logical trials, where there is a study done between open gastrectomy and laparoscopic gastrectomy that has been run by the Dutch colleagues, and the primary outcome is only the postoperative hospital stay, and other data regarding the lymph node retrieval, the length of stay, and even the oncologic outcome. And we are still waiting for the results of this trial. After that, after the logical, there is also stomach trial. Some Italian centers, I think Riccardo has also put some cases in this trial, where they compare laparoscopic versus open surgery after neoadjuvant chemotherapy. So even in this case, we are waiting for results. I mean, the preliminary confidential is that there is no inferiority of the laparoscopic, but we are still waiting for the official publications of the end results. So at the end, the laparoscopic may be feasible. We have seen, we strongly recommended for the small cancer. Of course, there are also many advanced that are treated, especially in the Western countries. But what is one of the problems of this technique? This paper published by Japanese is very interesting because they revise the large database, including more than 10,000 cases treated in the Japanese hospital, and they reported complication in the total gastrectomy, about leakage anastomosis or stricture of anastomosis, and how much was important and for the cases treated in this group. But I mean, we have to consider that this paper comes from Japan, so where all the centers included extremely large experience in terms of screening, very high number of T1 cases, and very skilled surgeon on the laparoscopic approach. So, and the complications at the end were comparable between open surgery and laparoscopic surgery. And they also analyze, as I said, the stenosis of anastomosis, the problem with the total gastrectomy, and some postoperative complications as pancreatitis from the low only amylase increase to a clear pancreatitis after the surgery. And this is the consideration of Terashima that Dr. Ng cited in the previous presentation about the report of Shizuoka Cancer Center, where there are some of the problems related on treating patients with robotic. Of course, we know that the use of the robots can give some interesting value. So I think that we are not going back from this technique for sure. So, and in my experience, if I have to choose on performing laparoscopic or robotic, I choose definitively robotic because of the details and many other advantages that all the colleagues that are performing and using robotic know very well. So there are some interesting things that are not really proved still by evidence-based medicine, but there are some clinical advantages. And first of all, in terms on performing lymphadenectomy, that is the most important point for the patients and for the surgeon, of course. Even for the extended lymphadenectomy, but even for the super extended lymphadenectomy as a posterior and para-aortic dissection that we have been performing in several cases for with this robotic technique. And so if we go and type on PubMed, of course, we see that the number of the papers has been growing in the last years regarding robotic surgery in gastric cancer. But the problem is that the majority of the reports are from the Asian court, and the difference between total and subtotal is not always specified as other aspect as well. So, but if we consider the real very good quality papers, the number is reduced to 19. And the sum of the studies that are more cited in the literature are again from the Far Eastern countries. About the safety and the feasibility, there are several papers. I just pick up some of more recent. There is no difference in mortality and the complication rate. In this case, we compare laparoscopic versus robotic. The most important aspect is the lymph nodes retrieval and the impact of the lymphadenectomy. If we just go to compare the case, the papers that have been published in the Western site, and are really few cases, the most evidence in critical points are the BMI. So mean BMI in the East is lower than West. The most important point is the number of T2N1 patients. So this group is very important and can really have a different outcome if the quality of lymphadenectomy is not perfect. In the Western countries, this group is between 50 and 17% of our cases. So here it's important to be very careful in the staging of the patients and really decide if this case can be performed in laparoscopy or in minimal invasive or should be performed in the open surgery. And other critical points are the tumor location. In the Far East countries, there is a predominant distal cancer with a less number of total gastrectomy. Instead, that in the Western countries, we have a more and more proximal form, especially, I mean, in Italy, in the north of Italy, but even in the rest of Europe, in the north of Europe, there is a predominant proximal form with cardiac cancer that are more complicated even with the minimal invasive approach. And here there is a report how much is the difference in treating laparoscopic and robotic. Even this paper has been cited by the previous speaker, and non c'è un laser point, no? And there is, it's interesting, see how much is the jump time that we usually is lost even in both techniques. But to reduce, it's important, of course, especially for a robotic approach, to train the team and and simplify the system setup. This is ongoing. I mean, we have seen the difference between SCI and XI, and maybe even from the previous models of Da Vinci. Another point is the learning curve. This is interesting because this paper published by Leonardo Soleni is trying to report how much is the number of cases that we need to do in the Western countries. And it's very interesting because we have the same number of cases when we compare with the largest series published by Chinese. I mean, we need 25 cases compared with the 22 cases from the Chinese to have a good learning curve for robotic case. And the pancreatitis maybe in laparoscopic is due to use of the cutter device, while in robotic, and I mean this paper is interesting because in robot maybe it's due to the fourth arms that is going to pull up the stomach or have some damage on the pancreatic capsula. But in the meta-analysis published only for Western cases by Leonardo, he reported no difference in terms of conversion between open and laparoscopy, no significant difference in terms of complications, anatomic leakage in terms of mortality. And this is referred only to Western cases. So for us, it's more important. Regarding the oncologic outcome and the number of lymph nodes, there are a few papers, only Chunky reported a superiority of lymphadenectomy of robotic compared with laparoscopy, and Caruso reported the contrary. So a kind of better removal of lymph nodes in laparoscopic versus robotic, but the end point is it's very similar even in Western patients. The oncologic results, so this was also reported by the previous speaker. It's important that it is true that there is no difference between laparoscopic and robotics, but even here we should consider that 75% of these cases are T1 and 0 disease. So it's very difficult to measure the technical differences with this kind of patients. In our series, we have analyzed 38 cases. We do about 50, 60 cases per year, but we have tried to select the really small cancer. It's not easy because we also included some advanced patients, of course, in our series, and the majority are distal gastrectomy, and complications in terms of anastomotic leak, anastomotic leak, and other surgical complications are very similar to the rest of the literature. No perioperative mortality, no non-surgical complications. Even the survival, of course, this is a very small group, so we cannot get really good details from this survival rate. And the last 3 slides regarding the idea on preparing an umbrella review that has been written by Luigi Marani, one of my young assistants, and he did all the meta-analysis of the old meta-analysis published on the topic, and that has been published in Updating Surgery. And from all the studies, there is I mean, a kind of safety in the efficacy of robotic gastrectomy is not clearly supported by strong evidence. It is in agreement with the previous speaker. I mean, some points like the performing of total gastrectomy should be considered with in a very accurate way and understand if it's really correct and analyze the data in the appropriate way. And at the end, we cannot have a robust conclusion from the data, even from umbrella review, because there are big variability between the different meta-analysis. So my last slide. So several clinical trials demonstrated non-inferiority of laparoscopic gastrectomy versus open gastrectomy. So it's feasible in minimal invasive, in our opinion, with a good selection of the cases. Robotic gastrectomy is considered, of course, a very important approach, and even if we need to use other new devices, but there are some advantages from that. There are only 12 Western comparative cohort studies that have been published to now, and the difference in complexity are associated with the morbidity between distal and total gastrectomy must be considered when we are going to interpret the results. And safety and efficacy of robotic gastrectomy is not clearly supported by strong evidence, even if longer operative time and lower blood loss are indeed associated with the robotic approach. We are trying to collect all the data of the gastric cases performed in this UGIRA, that is a European database organized by the colleagues from Utrecht, and we will see what happens in analyzing the data that are performed in the Western countries. Thank you very much.
Thank you, Franco. No, stay there because we are opening the discussion, so you can answer. You are the only one present. Of course, I think that the Korean colleague is still connected, so the discussion will involve her also. Well, I think that your talk was very interesting, and you touched many points. In one point I would like to emphasize, you said that there is a learning curve of about 25 cases, but when we speak of gastric cancer, in our country at least, we should have well in mind that more than 80% of hospitals do less than 10 cases per year. So about spreading of the technique versus trying to focalize in high volume center the quality, it's the first that have good quality of care. I think it's the first goal of our public health system. Otherwise, we will have a spread of cases that is not enough even to learn a good open surgery technique, at least for all the members of the team. This is the first. Second, in many issues, was extremely easy to see the advantages of minimal invasive versus open. It starts to become more complicated when we have to see the advantages of robots versus minimal invasive, because those are limited differences, and as far all the studies were aimed to short and long-term complication or long-term results, and at least those are non-inferiority. So it's very hard to say, and we still have the problem of the cost. So I don't know if Luigi, you wanna enter in this, because there are many things to discuss on this.
Actually, my question for you is, what you mentioned the issue of left para-aortic dissection, which is a critical point in gastric cancer surgery. How do you think the robotic surgery will change, is going to change the scenario, is going to change the routine approach we use, the protocols we use in those patients?
Okay, so first for Riccardo, yes, I completely agree with you. Of course, this kind of things should be only performed in the referral centers, where at least are performed between 30 and 50 cases per year. And as you mentioned, and as reported by our Ministry of Health, 80% of the cases are performed still in the hospital, where they do less than 10, so even less and less. And only the 10% are early, so it's even more complicated, the learning curve. But Leonardo did a very nice job, because he just analyzed only the data of a paper published from Italian centers. And so, I mean, that case 25 would be reasonable. Of course, if you do only 5-10 operations a year, it's impossible to have a good learning curve with this point. So I think that even for gastric, as for the esophageal cancer, it's we will have, or we need the kind of centralization, because it's becoming a more and more complicated disease to treat with a strong multimodal approach. Regarding the approach with robotic for para-aortic area, I mean, the para-aortic area is still very questionable. So actually, we are running a trial with one arm is D2 versus D2 plus. I think the robot cannot make a difference from this case, because first we have to understand if it's still really necessary to have a para-aortic dissection, and after that we can go through the technical things. It's only, I mean, robotic is technology. It will help us, but it does not solve our question, I think.
Okay, I have a question to Dr. Kim. Thank you very much for your nice talk. Let me ask you, in your department, which is the percentage of laparoscopic versus robotic gastrectomy? And first of all, and second, are those any form of different reimbursement from the national system if you do the robot? Is that private patients or a hospital bed cost for the difference?
Okay, thank you for great giving me a chance for a great conference. And first question is about the percentage of the laparoscopic gastrectomy and robotic gastrectomy in our country. Usually in our country, the early gastric cancer is the most of the gastric cancer. So we perform the more than 50% of gastrectomy in the year. We perform the laparoscopic surgery, and about 30% of the gastrectomy in the robot, and 20% of the gastric cancer underwent the open surgery. And the second second question is, I have one.
What was for the cost, if those are bad from the national health system, from the hospital, or from the patient?
From the patients. As you know, in our country, we have the national insurance systems of medical costs. Of course, our insurance our national insurance that cover robot costs in Korea so far especially for the gastrectomy. So there are, in my opinion, there is no benefit enough to cover this high cost compared to laparoscopic gastrectomy. But the insurance issues are not different in each country, and new robotic systems are being developed. So in the future, the cost issue can be improved, in my opinion.
In our country, I think that cost will be an mandatory question to look at, because hospitals have quite unbalanced, don't you think, Luigi? Any other question from the audience?
A short question for Franco. Very nice presentation, Franco. And as you have shown, one of the most demanding steps in laparoscopic total gastrectomy is the esophageal digital anastomosis. Do you think that robotic technique can help surgeons to perform this difficult step?
Yes, for sure. Yes, this is some advantages, because you can also perform as you do on hands-on suture. Yeah, I say yes. Not only me. I mean, I think it's clear in the literature also this point. There is no many reports from Japan, because they do small cases of total gastrectomy. But if we see all the numbers that they present, there are also data from the advantage of robotic approach in total gastrectomy.
Okay, if there are no other questions, I'd like to announce the, well, first of all, to say again thanks to Ugo and Fulvio and Francesco, and to announce the talk of Dr. Giulia Cambi, development and validation of an intraoperative bleeding severity scale. So thank you. You are representing Baxter.
Good morning to everyone. Thank you, Professor Boggi and Professor Calise, to have this possibility to present a new educational tool created by Baxter, Vibe Scale, the new validating intraoperative bleeding scale of intraoperative bleeding. When you think about all patients go through your operating room in a day, it's estimated that 1 out of 3 patients have surgery will have a bleeding-related complication. Based on data premiere, the author Stokes completed a retrospective analysis of 1.6 million of surgery, revealing that the average range of bleeding-related complication was about 29.9%, and that this incidence will be, of course, variable. We know that bleeding-related complication can be severe and will impact significantly on the patient health and hospital outcomes. For example, a blood transfusion alone can increase hospital stays by 3 times and increase the rate of death by 4 times. Plus, all these complications can increase costs and hospital resource utilization. These evidences was confirmed in the Sturck's paper, as you can see in this chart representing the different impact of bleeding-related complications on hospital costs and resource utilization. As you can see, when a bleeding-related complication happens, costs can increase a lot. For example, in vascular surgery, costs can increase more than 90%, or in general surgery, about 30%. We know that intraoperative bleeding is a common complication related to surgery, and a lot of risk factors, as the increased age of patients, comorbidities, and the high rate of anticoagulant medication can increase the risk of intraoperative bleeding. So how can you do bleeding stop? First, understanding the complex mechanism of coagulation is the first step, and we try to simplify this for ourselves and our customers. So what can you do to reduce bleeding complication? First, it's important to understand the hemostasis, a term that literally means stopping bleeding. As you know, when an injury occurs on the blood vessel, the body immediately responds to limit bleeding. This is what happens in physiological condition, but what could happen if patient coagulation status is compromised to the comorbidities and anticoagulant medication? Well, in this condition, patient could not be able to stop bleeding and risking blood loss. We have seen that bleeding is one of the main common complications related to surgery, often made worse by complexity of surgeries and the compromised coagulation status of patient. So the search of an adjunctive hemostatic agent able to accelerate stopping bleeding could be an efficient way to achieve hemostasis and to limit bleeding. However, not all patients are the same and have the same mechanism of action. So let's differentiate a passive adjunctive hemostatic agent from an active one. A passive agent is a physically mechanical agent, principally comprised by gelatin, collagen, or oxidated cellulose, which function either by platelet aggregation and contact activation. A passive agent relies on the patient's ability to generate clotting factors to achieve hemostasis. Conversely, an active agent functions independently of the patient's ability to generate clotting factors to achieve hemostasis. So they are effective across a large range of bleeding. And why that distinction is so important? Because, as we have seen, many patients undergoing a surgery have a compromised coagulation status. So the search of an active agent able to accelerate hemostasis, it's an effective way to limit bleeding. Clinical data demonstrate these evidences, and in particular that an active adjunct hemostatic agent can improve clinical outcome compared to a passive agent. And using an active agent is associated with a lower transfusion revision rates, shorter operative time, and a significant reduction of minor complications. These evidences led to development of innovation at the level of company's business. Why? Because in surgery, we witness a lack of standardization and consensus in defining the severity of intraoperative bleeding. As in orthopedics, the term fracture lacks of clarity and precision, also in surgery, the term bleeding indicates something vague and generic. But if we define the fracture, for example, as a closed oblique fracture or a disclosure fracture, we are able to, it triggers to a diagnostic thought process that lead to treatment. Similarly, in surgery, if we are able to define bleeding, we could be able to activate, to do the most therapeutic treatment in that situation, tailoring to the type of patient, a type of procedure, surgical procedures. This is the reason for that we have developed by scale, the first surgeon-validated scale designed for consistent and reliable assessment of intraoperative bleeding severity. Vice scale is designed to satisfy the need of regulatory agencies to have a clear definition of intraoperative bleeding, of hospital care teams to standardize evidences and compare hemostatic and sealant agents, and finally, the need of surgeons to select the most effective treatment for each type of bleeding. Bi-scale was designed in 3 stages, involve 100 to multi-specialty advisory board. And through a developer validation process involved more than 140 surgeons, bi-scale is demonstrated to is a valid, clear, and validated scale to evaluate the intraoperative bleeding, tailored to the type of patient, type of procedure, surgical procedure. Bi-scale was validated by FDA and then published in surgery paper in 2017 as a pre-cleaning publication. Bi-scale provide 5 grades of bleeding. Grade 0 depicted by this abrasion of kidney, where you can see no bleeding, but not significantly a clinical irrelevant bleeding. Grade 1 depicted by this capsular abrasion of the liver. As you can see, there is a capillary light mild bleed with blood loss between 1 and 5 milliliters per minute. It follows by grade 2, depicted by this vessel rupture of the left anterior marginal descending marginal vessel, where you can see a moderate bleed with blood loss between 5 and 10 milliliter per minute. Grade 3 depicted by this partial resection liver, where you can see a controllable spuric flow with a severe bleeding and with blood loss between 10 and 50 milliliter per minute. And finally, bleeding grade 4 with an identified or inaccessible sputum gush flow, life-threatening, with a low blood loss greater than 50 milliliter per minute. The definition of grades of by scale is based on anatomic appearance, quality description, and visually estimated rate of blood loss. You can see the increased bleeding associated with increased grades of by scale. But how can the by scale be used in the clinical practice? In clinical practice, by scale represents a valid, clear, and validated instrument for surgeons to communicate with the anesthetist and the OR team, so to plan the most effective hemostatic strategy tailored to the type of patient and type of procedure they undergo. So you can really start from the patient profile and in its coagulation status. So, for example, in patients with a compromised coagulation status or under an anticoagulant medication, the surgeon will know at the beginning that in case of severe bleeding, a passive agent will take too long time to work, and the patient could be at risk for intraoperative bleeding and complications relating to bleeding. However, in this condition, the surgeon will evaluate preventively which type of surgical treatment and which type of hemostatic agent used so that be effective in that situation. So in conclusion, what's BioScale? BioScale is a new educational tool creating a common language within the OR team to have an efficient identification, communication, and treatment of intraoperative bleeding, taking consideration of the type of patient, its coagulation status, and the complexity of procedure they undergo. Thank you very much.
Cambi, thank you for this interesting lecture. And Luigi, if you want to close the session.
So we are at the end. This was, I think, was a very interesting topic, and also the last lecture was very good. And thanks again to the committee for this invitation here, and Ugo for the invitation. Thanks.